Yeah. All right. Welcome to the future of mental and behavioral health. Excuse me. I'm one of your co-hosts, Bambi Francisco Roizen. I'm going to actually send it right over to you, Archana, because...
Yes. Welcome, everyone, to the Mental and Behavioral Health Invent Health Forum today. And I am Archana Dubey. I am Global Medical Director for HP, a co-host of this program. And we are delighted to have a panel of experts that are working incredible in their job sphere, doing incredible work in the mental and behavioral health space. And I am going to now bring in Bambi, who's had a sip of water, to jumpstart and share what about Vator and how that is supporting Invent Health. I do want to let you know that HP supports Invent Health and in sponsoring this event on a regular basis. We have been doing this for the last 3 years now. Talking about what the future of healthcare looks like in different arenas and spheres. And with that, I would pass it back to Bambi.
Thank you, Archana. And I'm sorry about that. I've been sitting here chatting away and I was fine until we went live. So welcome again, everyone. It's nice to see you populate, at least in the, for the speakers, I could see you. I can't really see the panelists. And I am joining you actually from Alameda. And I wish we could be there in person. It's so much nicer to have in-person conversations. At the same time, I've been feeling that I've gotten to know at least some of the speakers quite well, because we see a little bit of their personalities coming out when we see them in the comfort of their home, like you see me in my home. So there has been some interesting, and there's Mark Goldstein, who is in the comfort of his home. So before I have those opening remarks, before I dive into those opening remarks, why don't I bring in Mark, who is one of our co-hosts, and he could say a few words, and then Mark could throw it back to me.
Great. Well, I timed it well. Well, good afternoon, everyone, and welcome to the next chapter in the amazing Vator UCSF Health Hub series. Last two of these things have been really great, and on behalf of UCSF, I wanted to welcome everyone to this event. I know we have some great companies. I've had the privilege of being able to speak to all of the CEOs, so I'm really excited about the second part of today. For those who aren't members of UCSF Health Hub, sign up, become a member. What we're all about is fostering innovation across the digital health in the healthcare world, and mental health is a big part of what we do. So go to healthhub.com and UCSFhealthhub.com, sorry about that. Sign up, and I'm going to, you'll see me later on, and I'm really excited about today.
Thanks, Mark. And also, this is a 4-hour event, and I know that many of you won't be able to join us for that long, so please go to vator.tv/events so you can see the times as well as the speakers. And also, please feel free to chime in right away when the panels start. You can even do so now, ask questions in the Q&A box or ask questions in the chat room. And then also, if you can, tweet your participation, so this way we'll know, or if you hear anything that sounds interesting to you, go ahead and put that on Twitter so we know what's of interest to you. So right now I'm going to share my screen because there is a little bit of an opening here. I do want to thank some other partners that, that have helped us. So if you can see my screen, Vator, HP, UCSF Health Hub, we are the co-producers and co-hosts of this event, but we also have BetterHelp, which provides virtual therapy, and you can use Vator, V-A-T-O-R, as a code to get 50% off 3 months of virtual therapy. So thank you, BetterHelp, for offering that to the Invent Health community. We have Avison Young, which is a commercial real estate firm, advisor, boutique investment bank, Scrubbed, which provides online bookkeeping, and StratPoint, an outsourced engineering company. We also have American Psychiatric Association, Hapigo, OPTT, RIA Health, and Vinaj, which have also helped support this event. So thank you very much to our partners. So after this event, our next one will be the future of virtual care. We've already have, much like this event, we have 3 breakout sessions plus 1 main event. We've already had our first breakout session, but please join us for June 10th and June 24th, as well as our July 1st event. So you can sign up on that bit.ly account. So today, we're talking about mental and behavioral health. It doesn't sound like a great topic, but it doesn't have to be a horrible one. The fact is that we're talking about this more openly, and that's a good thing. That's positive. We're creating and driving more awareness to this. And we have to, because spending is significant. It is the most expensive condition, more and higher than cancer and heart conditions. Archana, I don't know if you want to add.
Yeah, I would add on that 200 billion is just the cost of the condition and the treatment and our ability to work and disability costs, that is to our lives and livelihood, that is unaccounted for. And then how these conditions do impact our other physical conditions, like diabetes gets worse when somebody has depression. Heart conditions do get worse as somebody has depression. So it is an important element for us to focus. It's easy for us to see an elbow injury or a heart condition. It is harder for us to see a mental and behavioral health condition. So we want to focus on that today.
And of course, now with COVID, we are seeing potentially another silent pandemic after the infectious pandemic. We may see the rise of another pandemic, a mental health pandemic, especially since COVID has sort of activated these underlying vulnerabilities that we've all had.
Absolutely, and if you look at COVID, has not only caused loss of life, wages, and also sickness. It is definitely not impacting 100% of the population, but the stress of it is impacting 100% of us. So
yeah, through the last 3 virtual sessions that we've had, this one we had in May, David Bond, you'll see David later today. He's at Blue Shield of California. He said that he saw more telehealth mental health in the first quarter, or Blue Shield California saw more telehealth mental health activity in the first quarter than in all of 2019. And you'll hear from all of our speakers that they have just been inundated. At this point, they're even looking to expand access and find more therapists or coaches. But here's a silver lining I do want to make sure people are aware of. When we talk about the rise in mental health or mental illness, it's not that we're seeing a rise in bipolar disorders or schizophrenia. What we're really seeing is a rise in anxiety and stress. And that is definitely not something we should have a stigma about, because we all have that. In fact, I wrote this was back in 2018, and I questioned whether we should keep talking about the rise or the stigma of mental illness. And shouldn't we just say it's really the stigma of flaws and inadequacy? And what I mean by that is that when we do have, when we're anxious and we're stressed, it's often the case that we feel inadequate to cope with the situation. So it's really important that people understand that this is something that everyone deals with. So there should be no stigma around our mental health. And one of the things that I think Archana and Mark and I have kind of sort of unearthed, and it's not really unearthing, but I think more people are talking about this, is really understanding the human condition, and that we are all broken, and that there's lots of times where we can't cope. And this pandemic is certainly showing that in all of us, that that we can't always be strong.
I also talk about how we are all broken. We are all not, quote unquote, the average patient or the normal person, because we all have our own quirkiness in ourselves. But I also feel like, from a positive perspective, that COVID-19 has brought the communities together. Prior to that, we did see, people divided up for social or political views. Today, everyone is standing to fight together against this virus. I see it in my community in healthcare and against this virus on the sickness level. But I also see that communities are helping each other out and bringing people together, even though we are quote unquote physically isolated, but we are socially connected. And it is unearthing that aspect. And hence we are talking about how can we optimize access and solutions that could be aiding us standing together against the virus and its silent pandemic, which is mental and behavioral health.
Along those lines, Archana, when you're talking about how we're all becoming united, I think that's something to be grateful for. And so one of the ways we can actually cope and deal with some of the stressors in life is to really be grateful for what we have. So for instance, in the shelter in place, I think many of us have adopted new routines for which have been good for our relationships and our mental health. I've said to other people that this pandemic has taken away what we wanted, but given us time to pursue what we need. So there is a science behind gratitude, and that's one way that people can actually manage their mental health. Now, what does this have to do with our conference? Well, do we need technology to be grateful? Do we need technology to help us think positively or connect us with people to help us understand our situation? And that's what we're here to talk about. Technology is an enabler of these new technologies, whether it's AI or whether it's just connecting with people who understand how to talk things through, like therapists. So we do need technology to be grateful. And then finally, this is something that I wrote recently in April as the country was thinking about opening up and getting to this new normal. This is me and my family, by the way, several years ago. But the question I've had is, who will we become? And throughout these conversations, we've all talked about certain aspects of our lives that have been hurt, but other aspects that have been good, like Archana mentioned, that have the positive silver linings. And so my hope is that through these discussions, we'll also talk about how do we take the good things of what we've learned through this process and bring them forward and become better people who actually know how to cope or know what the services out there, become aware of these services out there, and also just become aware of our human condition so we can be more open to talk about our mental health. So that's my opening remarks. We do have statistics, Archana, and it's 12:15, so I'm wondering if we should maybe show those statistics now, because I think some of the panelists are already on and we can share that. What are your thoughts on that?
Yes, absolutely. So we were initially thinking, I think that's a great idea. We were initially thinking of having our panelists to introduce themselves, and then we would share some of our survey data. But I think we can jumpstart with the survey data and then have their insights into what are they seeing in the survey data that is resonating to their own solution or business model and other things that they want to talk about.
Great. Yes. So let me go ahead and do that. So everybody, this is a survey. Most of you, a couple hundred of you, have taken this survey. So this is out of 200 people from when you registered to the event. And oh, by the way, let me just recognize again our sponsors below, or partners below, as well as the hashtags. So if you want to tweet something out, please use those hashtags. So here's some of the results that we found. Okay, so who's in the audience? Lots of startups, adopters. Those would be corporate innovators, the health plans and the providers, many investors and scientists and physicians. Here's an interesting slide. There are nearly half of the audience are millennials. And then we have Gen X. We have a number of Gen Zs, so that was nice. That was a nice surprise. They're the younger ones in the group. Here's a really interesting slide I wanted to share during our last breakout session in terms of what kind of access would you like. I mean, you can see on the right-hand side of that pie, therapists are therapist dominated. In fact, if just alone for a standalone type of treatment, we had 12% of the 200 said they would prefer a therapist, over 6% that said they would be okay with, let's say, a meditation app. And the apps are really apps, were gaming and meditation apps. And then if you add therapy plus other types of offerings, that really jumped up. So as you can see here, I think people, the in-person therapy sessions or virtual therapy sessions are still something people crave and prefer. This is an interesting one. 89% believe the current standards of dispensing psychotropics is a big part of the mental health problem. This is the similar question we asked last year. It's up from last year. 72% believed that the current standards of dispensing psychotropic is a big part of the mental health problem. So that was a big jump. And one of the reasons why we had this question there was because the conversation around the PCPs, primary care physicians, prescribing most of the medication seemed to be a big part of the problem. We also saw in 2020, 89% believe without objective diagnostics, then we should have a digital therapeutic solution in place. And that was up from last year as well. So more people believing that digital therapeutics are things that we should have in the arsenal. And then lastly, surprise, 85% of people believe religion is good for mental health. We asked this because last year we had a conversation around that. And this is also up from last year where 73% of people believe religion is good for mental health. So it's interesting survey results, and it would be great to talk to the panelists about some of those findings. Yeah. Okay, I'm done sharing my screen.
Excellent. Thank you for sharing. I think these are deeply insightful simply because the trending is in the directions that some that we anticipate, some we don't. So with that, we would like to invite our panelists. Are we ready to jumpstart Bambi and Mark?
I think we are missing Russ Glass and Todd. So I think we're missing Russ and Todd, but we do have Billy on the line, and we do,
yes.
I guess we're missing Nina as well. So we're missing Nina, Russ, and Todd. But we have, and Alon is there. Hello, Alon.
Hi, Alon.
Alon is in our second one, but in our second
I'm on the other panel.
I like that you're there. We've had 3 of these events, and of course this is, we created a bigger time in the beginning because we thought maybe if there were people who wanted to network, we're not quite sure how to do the networking online yet, but we thought that if there were people who wanted to network and raise their hands, and because I could see you, and so if you wanted to do that, you can certainly jump in and raise your hands. So, well, Alon, if you're there, since maybe you can talk a little, did you see the slides that we had in terms of some of the statistics that we found?
I saw some of them, and then I got disconnected and connected, so I may have missed some of them.
Yeah, well, I see Chris. Well, I mean, the one thing for you, there's Russ. The one slide for you was that the majority of people, or 55% of those who were surveyed, said they would like a therapist. It was actually it was 12% wanted therapy first, and then it was 6% who wanted a self-help app, a meditation app, or a gaming type of app. And then if you added therapy plus something else, that jumped up. And then if you added apps plus, that jumped up. But so that's good news for you.
Yeah, I think in general there's a little bit of fatigue from self-help, AI, and all kind of tools that are more on the soft wellness side, and especially now more of seeking the traditional professional help that has been tried and true for decades, and focusing more on the professional help from actual human being rather than from an automated bot or an app. And I think that's what comes out from the survey as well.
Yeah, so let me go ahead and share that again, just in case anybody is interested in seeing that. So again, who's in the audience? Not surprising. Here's the one, Alon, that we were talking about. So I think that's an interesting, let me just see.
Yes, and I think also what Alon is saying is that, you know, there is a place for intelligent tools, but they just need to augment the human experience. It cannot replace it. And that's what we are seeing, what kind of access you would like. It's not just an app. It is also an app that facilitates the user experience, but essentially you want to get to the therapist.
Well, we also asked the question about apps, meditation apps plus therapist, in person or virtual, and that was 6 times more. People said they like that. They preferred that over apps, meditation plus therapist in person. So people like the virtual aspect of it. And I think some people said that I have spoken to some therapists online, and they have said it's nice to be able to just look at the person on video, and maybe there's much more, there's a feeling of safety there. But anyway, that's an interesting statistic. This one is interesting as well, just for anybody to keep that in mind. And again, this is just the problem of the PCPs being the first person in line to see a number of these people. Archana, as a primary care physician, do you have a comment on this?
Absolutely. I think PCPs are primary care physicians. I would use the full name for it. They are in a unique position to be able to offer the right care if they're trained appropriately and they have enough time and resource prescribing. I would say resorting to medications, not over prescribing, but resorting to medications are few. One is that because of the billing and revenue model that's put in place for a primary care physician, the time with the patient is very limited. And in that time, you're not only addressing a mental health issue, which requires quite a bit of conversations and counseling, but they are also talking about diabetes or an ankle injury. And by the way, this mole is changing its shape and size. So all of those things are happening in a 15-minute visit. And then the best way a primary care physician can help this person right away to get quicker results is to prescribe a medication. So it's a system that isn't designed to foster a mental behavioral health conversation between a primary care physician and a patient. And then on the other end, they want to refer to a psychiatrist or a psychologist or a therapist, but the access in the community is so limited that the resources on the tips for the primary care physicians are also very limited. So it's a double fold problem, both during care and referral care or secondary care. And I think what Alon was talking about, that having that access has been possibly a success story for most of the solutions.
Yeah, and I think the other interesting statistic is that this move toward some digital therapeutics. I know we're still very early on that, and I know most of the startups that are joining us do have, even if they do medications as part of their solution, administering those medications more efficiently, they are also providing some digital therapeutic solutions. And I think we also have somebody in the startup presenter showcase, Sentio Solutions, that is trying to create objective diagnostics. So you could see that people, at least 90%, 9 out of 10 people believe that we need to have some digital therapeutic in place before we go ahead and I think this is what you're talking about, Archana, is that when your patients come to see you, what are some of these protocols where you could actually look at some of these digital therapeutic solutions? And I think that I believe NeuroFlow is also trying to arm primary care physicians with those protocols, and many of them would be maybe not so digital therapeutic, but they are at least processes that have been validated that that you now are informed with, and you can take those steps.
Absolutely.
So,
I'm excited to see the presentation. And with that, I think we have a full panel of panelists.
great.
We can start
here.
Yeah.
I see that we have, let's see. Well, we have Billy. He's over there by the Golden Gate Bridge. We have Nina, Dr. Nina Vasan.
Hi there.
We did have Russell, but I'm not sure what happened.
I see him.
I'm here.
Oh, you see him?
I see Russell.
Oh, you must be on the second page. Hey, Russ. And then, hi. And Todd, yay.
Todd is here too.
Did you guys see some of the survey results that we posted, that we were showing? Hopefully you didn't see them.
Yeah, I saw some of them. Thank you.
Okay, thanks, Russ. Okay, I
We
think
have
we're
Chris.
here.
Yeah, so everyone is here. So with that, we would like to welcome all of our panelists and would like to introduce and would like panelists to introduce themselves, because I think you can do a better job at it, and talk about your personal background and the work that you're doing, and then what is it that either in your position you're solving for, or your company is solving for, and then we can begin from. And I normally go by what I'm seeing on my screen, so we can begin with Russell, who is the top right.
Thanks, and thanks for having me.
On my screen. Welcome.
Thank you, and thanks for having me. I'm Russ Glass. I'm the CEO of Ginger. Ginger is an on-demand behavioral health system that is providing behavioral health coaching, therapy, and psychiatry on demand. We're available 24/7, and we primarily work with large employers to help them provide these services to their employees. So solve the access problem, provide preventative care in addition to serious mental illness care, and allow for destigmatization through a much easier access point than has traditionally been available.
Thanks, Russ.
Great, thank you, Russ. And can you share a little bit of your background too? So, what have you been doing prior to Ginger?
Sure, and clearly you're already learning that I don't listen to instructions very well. I am a multiple-time entrepreneur. I've founded or been a part of 5 different startups. My most recent one prior to Ginger was a company called Bizzo, which was in the B2B data space. We grew that, eventually sold it to LinkedIn, and then I ran the marketing solutions business at LinkedIn for about 3 years. The product group was about $1 billion piece of LinkedIn's business at that point, fastest growing piece of their business. And then left there, take some time to be dad, and decided that I wanted to get involved in something that needed to exist in the world, and came across Ginger, and I've never seen a bigger supply-demand imbalance than exists in the mental health space today, where far more people need care than have access to care. The curves are diverging. There are far more people who are presenting with issues, and then there are fewer providers going into the field, and we're trying to specifically solve for that supply-demand imbalance in the mental health space.
Great, thank you. And Nina, you're next on my screen, so I will pick on you.
Hi, everyone. I'm Nina Vasan. So first and foremost, I'm a psychiatrist at Stanford. I treat patients both at Stanford, and I have a concierge practice for executives and entrepreneurs. So from that perspective, clinically, I really get to see a wide range of folks here in the Bay Area. Then I'm a professor at Stanford, and I run a lab at Stanford called Brainstorm, which is Stanford's lab for mental health innovation. And basically what we do is we both research and create products in mental health technology. We work with folks ranging from small entrepreneurs all the way to large tech companies, and think about how we can really democratize mental health care by providing tools that will allow everything from improving diagnosis, treatment, management, all of the above. In terms of kind of also, supporting innovation, I chair innovation for the American Psychiatric Association. And what we're really trying to do there is bring together the different stakeholders in the field: psychiatrists, entrepreneurs, investors, engineers, patients, and kind of really get on the same page, build a shared language around innovation, and really making sure that we're addressing the right needs for the right people at the right time.
Great, thank you. Welcome to the forum here. Billy, you're next on my virtual presence here.
Great. Hi, everyone. Russ, long time no see. Good to see you. Todd, I think this is our second panel in the past couple months. Good to see you again as well. Nina, nice to meet you. My name is Billy Deitch. I'm an investor at OKHCFT. Hopefully my arm's not popping up, but they're somehow on my new fancy background that they sent me to use. You see the logo there. Excited to try this out. We are a venture growth equity fund focused on investing in healthcare and fintech. That's the HC and the FT. We've got about $2 billion of assets under management. And on the healthcare side, which is where I spend all my time, I'm based out in San Francisco and lead our West Coast efforts. We focus on investing in companies that improve access, lower costs, and improve the quality of care. So that's all we're focused on. And we have a big focus on behavioral health as well as physical health. On the behavioral health side, we've invested in companies like Quartet, a business called Axial, which is focused on addiction management, addiction treatment, US Health Fest, which is much sort of higher acuity mental health care. It's inpatient acute psychiatric facilities. And then our most recent behavioral health investment is a company called Emilio, which we have the CEO, I think, speaking on a later panel here, Naomi, Alon. And Emilio is focused on providing behavioral health services to kids and families. So an area that we thought was sort of under-addressed and a really big pain point. My background is I've spent the past decade plus focused on investing in healthcare and technology businesses. And on a personal side, as it pertains to mental and behavioral health, my wife is a clinical psychologist as well. So I sort of every night at the dinner table, I'm hearing about the pain points that the industry faces. I've seen her shift to telehealth. She's down the hall from me right now, speaking with her patients via Zoom. So I've seen that day in, day out. And her mother is a psychologist, her aunt is a psychologist, her cousin is getting his doctorate, her sister's getting her doctorate, her dad is a neurologist, so a lot of brain focus on that side of the family. So I've sort of seen all this day in, day out, and it's very personal to me, and an area that I'm extremely passionate about, and trying to make is increase access, lower stigma, everything we're talking about here.
That's great. So you have the best access to mental and neurological health, I believe.
I have a lot of access to it. That cuts both ways, but I have a lot of access to it.
Excellent. Hey, Todd. I see you next, and thank you for joining us.
Oh, great. Thanks for having me again. So Todd Czartoski, I'm a neurologist by training, but really have been in the virtual care telehealth space for the last 12 years or so. Ran a large neurology department up here in Seattle for a number of years before switching and going solely into telehealth. I'm at Providence, St. Joseph Health, which is largely a West Coast health system, stretching from Alaska to Texas and 7 states in between. As the chief executive of telehealth, I oversee a number of enterprise service lines, including behavioral health and telepsychiatry, both on the acute side and the ambulatory side. And then probably one of the more interesting things we've been doing in the last really since COVID and even several months before that has been around what we call caring for our own caregivers. So a helpline for our own stressed out frontline providers, nurses, physicians, really anyone and their family members to be able to talk to someone to handle the stress. And not surprisingly, we're seeing a huge spike in activity around that in the setting of COVID, which is kind of a delayed spike after we saw the activity of increased patients. It was about a 6-week lag, and then we're seeing this continuing to rise, stress levels and mental health and behavioral health issues. So glad to be here and glad to be part of the conversation. Thanks.
I think the one thing, thanks everybody. The last few times we did this, we asked everyone to introduce themselves and then also talk about how COVID has impacted your businesses. And Todd, you started going down that direction in terms of how COVID has impacted your business. And I'd love to hear from everyone else as well, because I know, Russ, you and I spoke early on, maybe early March, and you were already, or mid-March, and you were already seeing that uptick. So I'm sure it's gone up since then. But let's go ahead and if Todd, if you want to kick it off and let us know how COVID impacted your business early on and what are you seeing today?
Yeah, it's largely what I mentioned. It's largely been our own caregivers and the stress related to it. And I guess the other interesting thing is just, family members. So we've seen a spike there as well. And I think it's probably a manifestation of the quarantining and kind of the being at home for such prolonged periods of time. And I remember, Bambi, the last one of these we're on, I think one of your kids was in the background for a brief period, and I can relate to that because it's happened to me a number of times as well. And,
Did I tell you about the one son who moved out into the tent in the backyard? Was that him or my other one?
I'm not sure which one it was, but I can empathize because I've got 3. We've got 3 in our house, and they're all on video classes now for school, and it definitely has disrupted our family life. So imagine that. And my wife and I are both in healthcare, and so handling that and handling the homeschooling and everything else. So not surprising at all that I think probably everybody on this call has had. Their services have probably seen in fact, I'd be surprised if we're not all seeing a spike in activity in the current climate.
Do you see? Go ahead.
I was gonna go around to find out how COVID's impacting everyone's business. And I know with Nina, she talked about a rise in what she was seeing was a rise in substance abuse and PTSD. I'm assuming it's the same or maybe more or different.
Yeah, absolutely. So I think echoing kind of what Todd is saying as well is that I sort of have seen, I'd say maybe 3 major changes. One is in just the demand itself and the number of people who are asking for help, where, we already talking about one of the biggest supply demand mismatches probably in the world. It got even worse, basically, right? And so longer wait lists, more people who are really needing that help. So one is the demand. 2 is the culture around mental health. And in this case, I'm really going to go with the stigma, where stigma has decreased so rapidly in just a short amount of time. And 3 is the actual the pathologies. And so I'll go back just a little bit. So, when we think about the demand, already really big. And I think that initially we were in this phase where people were struggling, but were not wanting to engage with the healthcare system as much. And then now over the past month, kind of similar to the pattern that Todd has seen, we really have seen this big increase in people wanting to get help. And I think what's important here is when we look epidemiologically of past occurrences like this, that we expect this rise to continue for the next several years. So that's number 1. Number 2 is when I talk about culture change. I think that when we're all thinking about so many ways that we have changed as individuals, as companies, as societies, as a society over these last 2 months, what I'm hearing a lot of people talk about is that, it's not so much change as much as it is acceleration, where something that might have happened 3 or 5 years from now has now happened actually at this accelerated rate in this 2-month time period. And I think that stigma is a really good example of that, where, we hoped that it would get better in many years, but it hadn't. And while there's a lot of really tough things we're dealing with right now, I actually have found this to be the silver lining for myself as a clinician, in just seeing how many people are now talking about struggling themselves, having anxiety, struggling with stress, and wanting to get it out there, wanting to talk to others, and then of course wanting to get help about that. And so that's really been a gift. It's not only that individuals are talking, but the media is talking about it as well. So like every day the New York Times has some article on anxiety and on trauma. And so just for this to be now a continual part of our national dialogue, I think is really important. So that's what I would say is the great thing that I've seen. And then finally is the pathology. And exactly like you said, Bambi, I think that what I'm really seeing is a increase in certain pathologies versus others that are kind of going on more on the back burner. And that starts with anxiety, this collective anxiety, trauma, collective trauma that our whole country is going through in different ways. And then we have depression, suicidal ideation, and substance use, which have been really, really rampant. And folks where, these are all, there's a lot of interplay between these, right? Someone who's more depressed is then going to be more likely to drink, for example. And that's really what we're seeing, this meteoric rise. And then finally, areas that are not necessarily always thought of as like psychiatry, but domestic violence and child abuse have really gone up. And that's something that's incredibly concerning for us as a society.
Thank you. I want to get to Russ, but first I did share the screen with you. Nina, I don't know if you were on with when we had our opening remarks, but it's something that you and I and Archana and the other panelists had a discussion on at the last breakout session, which was kind of understanding the human condition. And that's why we're seeing stigma come down, is that we're all finally feeling okay that, yeah, we're kind of broken and we do need these services. So thank you for touching on that again. I wanted to bring that slide up. So, but Todd, Russ, you have been very busy since early March, I mean, even before that, but for sure, you and I were emailing each other and you were talking about how much just increase that you were seeing back then. Has that continued, and how has it changed?
It has continued. There's been a little bit of a leveling off. As Nina mentioned, obviously there was this huge supply-demand imbalance pre-COVID, and all of a sudden COVID hits and there's a spike. I think some examples are our clinical volumes up about 200% over the last 6 weeks compared to the 6-week period prior. Our monthly actives are up probably about 80 to 100% at this point, which again is a little bit of a leveling off. It really spiked and then it sort of leveled off at that higher level. Our intensity is up. So we measure the intensity of conversations, part of how we do the supply-demand matching that we do. That's up about 30% compared to the period before. So how intense are these conversations? Our entry PHQs and GADs, or how clinical is somebody coming in, are higher. So we've gone from probably about 40% of the population presenting with clinical need versus subclinical to about 55% of the population presenting with clinical need. So we're seeing more people require referral to clinical therapy or psychiatry. And some interesting insights. I think it touches on the stigma reduction, which completely agree is a positive thing, but we're seeing that this is very much affecting men more than women. And it's presenting in a number of different ways. One is that we used to see women approach Ginger and ask for help from Ginger at a far higher clip than men. That's flipped during this period. So we see far more men showing up than women right now. And we think part of that is the reduction of stigma. That it's not that these men didn't have a need before, but part of it is that stigma has been reduced, so they're willing to reach out for help. The second thing we think in some of the research we're doing is that women historically have had more balancing to do between career and home life. And so this isn't as big a shift to women as it is to men who didn't have all of that balancing to do before. And now they've got work-life, family balance that they're trying to deal with. Everybody's at home at the same time. So there are some differences. You know, the final insight we're seeing is there's far more utilization, about a 50% increase in overnight utilization. So we are available 24/7, and historically, a minority of our sessions would be between that 10 p.m. and 6 a.m. period. Maybe 25, 30%. That's up 50% during this period. So far more people are having trouble sleeping. They're showing up in the middle of the night and accessing the services because of this period.
Hey, Russ, not to get into a gender discussion, but I was speaking to a therapist who said that said the same thing, had the same observation as you have, which is that there were more men seeking these services now. And I think a lot of it has to do with the fact that they found their identity outside of the home. They got their sense of agency outside of the home, whereas women were okay at home. For instance, I've said this, many people have heard this, I get very domesticated right around 5 o'clock when I start cooking dinner for the family, and that's okay. That's my sense of agency. So I think that was another reason as well, in terms of this lack of purpose, because it's typically your identity is found outside of the home.
That feels right. And I think it's presenting in multiple different ways. Men right now are struggling to attend meetings at the same rate they did before. They're taking more mental health days than they were prior. They're seeking out help more frequently than they were prior. And my hope is that sticks, right? My hope is that this stigma reduction is something that allows men to reach out for the help that they've needed, and never more so than now.
Do you think that it could be related to, of course, the job loss and other things too, because that is quite intense at this time. But also the fact that when somebody has to go to work, they are to some level performing to the outside world. And now that there is time that they are having contemplative time, that they are actually addressing some of their issues that they have needed to address for a period of time, because those are a couple of things that I'm seeing in my clinical practice that are coming to a head at this point.
One of the things we're seeing, the men that we have coming to our service, since we're supporting employers, they haven't lost their jobs. They may see a risk of losing their jobs. Their partner may have lost income. Mm-hmm. So I'm not sure in our world if we can definitively say that it's because of reasons like job loss or whatnot, but we certainly see that financial pressures are felt more by men than they are by women. So there's a sense of identity to providing for the family that I think is felt in a more strong way by men than necessarily by women. And so that may be part of what's going on here as well.
And to bring Billy into the discussion, I don't know, and again, I don't want to make this a gender discussion, but to the extent that you see a lot of your portfolio companies, to the extent that there's a greater portion of men than women you funded, what are you seeing? It doesn't have to be it doesn't have to be again about a men versus women conversation, but perhaps you are seeing more of your founders, your male founders, more open to being vulnerable. That's one question. And then the other question is, what are how are they dealing with COVID now that we're 10 weeks, 11, I've lost count. Where are we, 2 months, 2.5 months in? Are they settled? Are they still worried about running out of money? And what are their concerns?
Yeah, well, good question. I haven't thought about it from, are the male founders more vulnerable? I don't know. That's an interesting question. I need to think about that. I do. By the way, I thought the stats, the data you have, Russ, is really interesting. Just to be able to sort of see that in such a tangible way, just more people logging on and what that looks like and the intensity of it. That's fascinating. Sort of firsthand data that I think would be pretty tough to get beyond anecdotally. But I think, a few things happen for the majority of our portfolio companies. The first month or so was making sure everyone's liquidity, or if they had debt, that the covenants were managed or whatever it might be. That was the biggest focus. Some of our companies had just raised and they were fine. Some companies had raised but needed to reduce burn, and just because of all the uncertainty, we were pretty fortunate that we didn't have any companies that were having to shut down business altogether, which happened for a lot of folks. Like if you were invested in a bunch of dental practices or something like that, you were shutting down, and that was exceptionally challenging. We have some brick and mortar clinic businesses, but they were deemed essential enough that they were able to remain open. This is something that Nina touched on. I think there was sort of, after people's liquidity was managed, and that's generally been got through that pretty well. I think we were fortunate in our portfolio, but then it started to be like, okay, well, how is this going to change our business and how we operate? And Nina talked about silver linings that she was seeing. I think some of the silver linings that we saw was acceleration of offerings that had always sort of been on the landscape and on the product roadmap, but really got pushed to the forefront. And telehealth is number one on that front. It was saying, well, we want to have telehealth services. We'll get there. We've got a lot of stuff. We don't need it right now. And because there was this mandatory shift, whether that was a behavioral health business or a primary care business or whatever it might be, or even people working remotely, right? It forced the company to say, well, how would we do this? How could we do this? And let's do it right now today. And I think a lot of this is going to be, become how the world operates. Even, some things, when there's a vaccine, things will go back to quote unquote normal. Some things will remain. And I think all of us have probably had a telehealth visit for certain things and said, wow, that works pretty easy. And I don't have to go to a waiting room, and I don't have to, leave my home. I have to drive and look for parking. I have to do all these things. Now I think we've seen with some of our businesses that we accelerated things we always wanted to do, and because we had to, and they're going to be long-term parts of the business. So that's been great. And then I think, we're starting to now figure out, okay, well, we got through sort of the firefighting part of this. Now, what does the rest of the year look like? And I think that's really hard. It's really hard to say because, there are some services that people are just buying, rapidly. Zoom licenses, right? Super obvious one. But other things, it takes time, and it's hard to get a sales cycle going. And, whether you're selling to employers or to health systems or to payers or whomever it might be, budgets are so uncertain for everyone that it's kind of hard to say like when people will be buying, even if it's a service that they really need, whether it's something like Ginger, whether it's workflow automation tools or things that deliver clear ROI, saying, wow, if we invest these dollars, we'll get it back very quickly. It's still hard to say what our budget is because the health systems were so impacted by all of this, and the payers were so impacted by this. Employers are so uncertain how many employees they're even going to have. So I think that's the challenging part right now for not just healthcare companies. Every company is selling to enterprise customers is a tricky thing right now, and a lot of uncertainty, no matter how strong your business is. So that's sort of the next stage of this, I think, for a lot of companies.
I think that what we're hearing is, and Billy, you kind of rattled off a bunch of those needs that we're starting to see. that this COVID has exposed. And one of the things that Russ brought up was the need for more male services. And it's interesting because this is our 4th event, and I don't think that conversation has come up, Archana, regarding this identifying that that male founder, or that males, we're starting to see more of them come open up and say they need these services. And so I want to bring in Nina, because I know she works with a number of male founders, and you have some interesting insights there.
Yeah, absolutely. So my private practice, it's a concierge private practice specifically with executives and entrepreneurs. And so, being here in Silicon Valley, that means investors and large tech company CEOs and folks like that. And what I really have seen exactly kind of the same patterns that Russ has seen at Ginger, of male founders and executives who are now a lot more, folks who I was already treating and working with in some way, who are having bigger crises and wanting to talk about it and get that help, as well as just new people who had never addressed their mental health before, approaching and wanting to figure out what's going on with me and how do I get this treatment. And I think that in terms of what I'm seeing, there's an immense amount of anxiety and panic attacks in particular. I think that that's something where in the past, has just not been so much of an issue. And the number of folks I've seen where, and so because I have a concierge practice, I text my patients all the time, and they kind of, I let them call me whenever they need to. And so like, truly, I've had like a large number of like 3 a.m., 4 a.m. calls of people waking up in the middle of the night and feeling this chest pain and not really knowing what to do about it. So it's definitely there. I think that what I've seen, in addition to what Russ was talking about this theory of not really being able to have the work-life balance, that there's also, I think, this immense sense of the responsibility you have to your company, right? So if that's anywhere from, small startup having a small team where they feel like a family, all the way through having, thousands of employees, that stress and burden of recognizing it's not just your own mental health, but that your employees are going through an immense amount right now as well. And so how do you serve as a good role model for them, both in modeling your own desire to express your struggles and getting that help, as well as then making sure that the resources, the conversation is open for them to get that help. And so I think that it's like these dual roles, right? Personal, professional. There's so much increased stress and mental health struggles for everyone there, that the male entrepreneurs and executives are really trying to figure out what their role is in there and how they can get that help. The next thing though that I'll add in, because I think what I love so much about Bambi and Archana, what you're doing is really thinking about solutions, right? So what are we going to do about this? And one of the lines that we have, I think about both in private practice and when, creating products, is meet people where they are. This is one of the classic lines we have in psychiatry around how we think about how we talk and educate, with how we talk to and educate patients. And so I think with that approach, what's been great is is when we think about technology, one is this huge increase we're seeing in telehealth and telemedicine, but also the creation of a lot of tools, simple tools, things like, mobile apps or new ways that we can utilize devices, where we're really going to where people are and thinking about how we can reach them and give them simple ways to be able to address their mental health. One of the things that we did in my lab at Stanford is we worked with Pinterest, and we created a toolkit around stress, anxiety, and self-harm and suicide through the app itself or through the website, where people, they were going in and typing, how do I deal with stress, or tips for anxiety. And we put out evidence-based tools using CBT, mindfulness, gratitude, things like that, and things that they can do in like 1 to 5 minutes, these little bite-sized things that no matter who you are or where you are, you can really get that benefit in a short amount of time. And so I think that what I'm seeing from the lab perspective is everyone from these like small entrepreneurs through the big companies wanting to create these sorts of tools, wanting to think about their employees, wanting to think about their users and customers, and trying to understand what's going on and how they can uniquely use their platform to address that. And we're talking about, Instagram and TikTok and Twitter and all these folks where they know they have millions of people who are struggling. What can they offer them that's going to really help?
That's great, and it is something that's also quite unique for Todd's population too. If you look at healthcare professionals, for example, and they are high performers, but they are also receiving quite a bit of trauma in their workspace, especially there's loss of life and the severity of illness. What are you seeing, Todd, that is very unique, especially, knowing that you've led this, this position for a while, and that what you've seen in the past versus now post-COVID in the healthcare community, which is very unique.
Yeah, so I should clarify, right? So I'm a neurologist, so right organ, but maybe not quite the right specialist. But my team, our team, I can share some anecdotes. We share a lot of safety stories and reflections as part of our culture when we're doing meetings in the organization. And a recent one that resonated with me was a frontline caregiver who happened to nurse who just couldn't shut it off after experiencing, and really it was PTSD around the frontline exposure to folks in acute respiratory stress and respiratory failure related to COVID, and being in a COVID unit and seeing that respiratory distress, and not just one patient, but dozens and dozens of patients left this caregiver with limited ability to cope, and it was really hard to sort of get beyond that after leaving 12-hour shift. And so I think that's one. Again, I was saying earlier, unfortunately, I think we're just starting to see the beginning of some of those types of presentations, and suspect that, regardless of what happens in the fall, and if there's a second wave, it clearly is going to make things much worse. But, I think the totality of frontline caregivers having to address that on top of all the other life changes that are going on has been fairly traumatic for all types of caregivers and across the spectrum. I would say one other one, and we have like Nina and others, we quickly turned on a lot of providers. So we have about over 12,000 providers right now doing virtual visits, in some capacity, face-to-face video visits, and we're doing right now we're around 15,000 a day face-to-face video visits, and in the inability, at least early on, this has gotten better because of people quickly adapting to telehealth, but early on, the stressor for particularly a lot of our primary care docs, but some of our specialists too, feeling helpless to be able to care for their patients, right? So a lot of them quickly adapted and started with phone calls and e-visits and sort of secure emails to check in on their panel of patients, and then they quickly evolved to video. But I think professionally and personally, that was a really big deal for a lot of our caregivers. So that is part of their identity, and being able to care for that person with brittle diabetes or CHF or whatever the case might be, and not being able to do it in the way that you train and the way you've practiced for 20, 30 plus years, really, as was said earlier, force the issue for people to be able to adapt in a very, very short time frame. And that's been very stressful for our caregivers, for sure.
That's so interesting that, Russ talks about how identity is one of the reasons why men are reaching out to help. And then also, about that, how not their own personal need, but the stress of supporting their teams and companies, and not having their people that work for you losing their jobs becomes a stress for an entrepreneur or a leader. And then now healthcare professionals. So there is a common link of assuming an identity of being a caregiver and not being able to deliver is playing out a pretty big stressor for across all genders, roles, and responsibilities that people are bearing on. And I think what Nina mentioned is that the asynchronous communication is starting to spur up, which is like, you set up a meeting with a doctor, which is a synchronous visit, where you secure secure a time and meet. But it seems like meet people where they are through texting or calling anytime is possibly a very effective and powerful tool to be able to offer. Nina, how do you manage that in your environment? How do you work that as part of your workflow and to make it sustainable for a caregiver?
Yeah, great question. Well, one is that I think that there's sort of both the individual provider side of that and then the kind of broader system side of that, and I can speak to both. As an individual provider, this is something that I think personally I have found to be something where, it does take a little bit of a toll on me as the provider. Do I like waking up at 4 a.m.? Not so much. I am lucky I can go back to bed pretty quickly. But what I've seen, and the reason actually why I've been pretty adamant and in wanting to be very true and focused on my own self-care and not burning out as a provider myself, but still providing the best care to my patients, is that I really feel like in being able to contact me at all times of the day and even like text on certain things. When, we always talk about prevention and how horrible kind of we are as a healthcare system to address prevention. I feel like it allows for that. And this traditional model is completely antiquated and not really based on anything other than convenience of like, let me see my doctor or therapist, once a week at 3 p.m. in the middle of the day, right? Like that's not when shit happens, excuse my language. And so if you can reach out at the moments that you actually are in crisis, or even like, when you realize things are starting, the 23/7 or, like every time other than when you're actually in the traditional doctor's appointment, I just see people getting better quicker. And I see that, things that might have happened, it gets prevented, or the severity of something goes down. And I think that's one big part. Another, I'll just talk about it really. I've had it, and I'm almost blown away by the number of panic attacks I've seen in entrepreneurs and execs just in the last few weeks, actually. And I didn't see it in April. I'm just seeing it now in May, actually. But being able to talk them through it instead, like imagine the cost of them going to the emergency room and realizing, okay, my troponins are negative and my EKG is fine, and it turns out I have a panic attack, and that's like 3 hours, thousands of dollars. But being able to call me and talk through it in like 10 minutes, that's saving a lot of money to the system. It's making them a lot better. And they're learning the tools, so in being able to talk to me, it's not just going to the ED and getting that diagnosis, oh, you had a panic attack, but we like literally in the moment talk through cognitive behavioral therapy practices, and I'll do deep breathing with them. We'll like get, maybe they like Calm or Headspace, and we'll get that out and do it in session together. And by session, I mean, at different times. So I basically, it's like, I do think it's really important to like figure out your own boundaries. And that's something that we learn in training and is important with each patient. Actually, some patients, when I say concierge, like that makes them think I can literally contact every single day and expect a response in like 5 minutes, and so it's like recognizing what does that mean, and who kind of can have the right relationship. But that's really, I think, just open communication with your patients on here's what we do, here's why we do it. And I found everyone to be really respectful and use it in an appropriate way. That's the clinical side of things. Then I think when we think about the broader scale, like how do we democratize access to care? How do we scale these tools in a way that's going to be really meaningful? On that side, I think it is about finding tools that really like partner with the clinician or can be helpful in addressing some element of mental health if the clinician isn't there. And at the end of the day, when we think about the supply-demand mismatch, the key factor there is that it's all about the number of like clinicians and clinician hours. And ultimately, we're not going to have a great like systemic solution if there's still that bottleneck that exists around the clinician being, that kind of last point. And so the way to go about this is by having additional tools. Technology is amazing here, that can do things like maybe it's before you see someone, you take the online version of the PHQ-9 or GAD-7, which are kind of standard metrics for being able to diagnose if someone has depression or anxiety. And then using that, and that being a way for you to realize, oh, wait a second, I'm actually fine. Maybe I just need to like exercise a little bit more or do some mindfulness. Or on the flip side, no, I actually really, really need that help. I had no idea things were that bad. Let me call a doctor and figure out what I need, right? So that's sort of thinking about triage. But all steps from diagnosis to management, treatment, collaboration, all of these, there are really important tools that companies are developing that I'm sure, Billy is investing in right now, to think about how we can be a good partner with the healthcare system and use that to expand care.
And Nina, it's great because you're speaking really as a clinician, right? And so you know what you need. You're only one person, and you're trying to enhance your services by having these multiple tools. For Russ, I know that he also has a network of clinicians. And what's interesting with you, Russ, and maybe you can talk a little bit about how you're going about using technology to enhance your therapist, also enabling the people who do come into your system. How is technology being used? Where's the handoff? And what's the population of your network look like? I mean, they're not a bunch of Ninas, because that would be way too expensive, I'd imagine. They would be, is it a number of social workers? Is it a number, how are you creating access with technology, with maybe lower level therapists, not lower level therapists, don't mean to say that, but in terms of different certifications to meet access, to meet the demand?
Good question. Ginger recognized that there was this huge supply-demand imbalance pre-COVID, and so looked at the way the networks were built today, looked at the way things were trending, with anxiety rates, depression rates, suicidality rates going up, with the number of new providers going into the space going down relative to the numbers that are retiring, and recognized that we had to take a different approach to scaling care. And the system we've designed does that in a number of different ways. The first way is everybody who connects with Ginger is assigned a longitudinal behavioral health coach. So any time of day or night, you have access to a behavioral health coach that is able to both understand what your needs are, but provide 80+% of the care on the Ginger system. So most people that are coming in in a preventative care subclinical modality, and the coach works with them on how they can move forward with both self-care opportunities as well as just accountability to make changes that will help them with their mental health. So things like motivational interviewing and SMART goal setting and mindfulness routine, exercise, etc.
Russ, before you move on, what does it take to be a coach?
So they tend to be master's level in psychology. They tend to have behavioral health certificates, coaching certificates from one of the large universities. UCLA provides them, Columbia, Duke, Michigan. There are a number of programs around the country. But they are not providing clinical care. So it's an important distinction. It's similar, but they're a lower level license to what you might see in population health, where you have physician's assistants, or you have NPs providing care at a lower level of licensure than an MD would provide, but they can handle 80% of the need. This is similar to what we're using behavioral health coaches for. So these coaches are longitudinal, and let's say 20% of the time, more care is needed. Whether our technology is recognizing that, because we're monitoring these conversations and making recommendations to the coaches. The coaches have clinical oversight, so the oversight might see that somebody needs a higher level of care. Or we're just seeing, as we measure, that people aren't getting healthy as fast as we'd expect them to. That's when they'd be escalated to a therapist. But different from a traditional network, we're not referring out to a therapist, we're bringing a therapist into that care team. So now you'll have a behavioral health coach and a therapist. That therapist is providing video-based sessions. If medication management is warranted or needed, a psychiatrist will then be brought into that care team also. So now you have a collaborative care team of 3 different professionals. And the key to this is those behavioral health coaches are designed to work with the clinicians to make sure you're accomplishing between sessions what the clinician wants you to accomplish. Because ultimately, we want you to graduate from that higher level of care as soon as possible. And then we want the coach to act as step-down care so you can continue on your journey once you've had the work with, let's say it's DBT or CBT with a therapist, or now you have a psychiatrist ongoing titrating medication, but now the coach is working with you on what they want you to work on. A few advantages. One is we can provide 24/7 care. Two is it's far more scalable. There are far more behavioral health coaches available. There are far less expensive resources. And three, we minimize the number of hours that are needed at the higher licensure so that those hours can go to the next person in need of those hours. And with this design, we're providing an order of magnitude more evidence-based care than we'd be able to provide without this way of doing things.
There's a question from Arnold for you, Russ. I'm not quite sure if he wants to ask that question, but I'll just ask it.
Yeah, he's on. I think he would ask the question. Yeah.
Yeah, Russell, it's really interesting in terms of your model. I like what you guys are trying to achieve. I'm curious about when you assign a coach to somebody, and what happens in the off hours. I mean, is the coach available, that specific coach available for that person, available 24/7, or do you have a backup kind of coach? I mean, it's people with concerns are going to ask when they need to ask, and it's unpredictable. So I was just kind of curious about that.
Good question. As you'd imagine, our coaches have to sleep also and have to focus on their own mental health. So they're not 24/7
right.
individually, but we are staffed 24/7. And so if you come in the middle of the night and your primary coach isn't available, you'll have a choice. You can either get access to a new coach that will be added to your care team.
Mm-hmm.
So we'll share the information with that coach. They'll do a quick update on what your history looks like. And now they're part of your care team.
Okay.
Or we will notify your primary coach when they're online to reach back out to you. So
okay.
It's the member's choice as to how they want to handle it.
Got it. Okay, so they have the option to choose whatever. Okay, that's good to know. I was just kind of curious because it's like, you're right. The coaches need to sleep. Those need to be, they're set. The coaches have self-care. So thank you.
Thanks for the question.
Hey, Todd.
And then also, as a quick follow-up to the question that was asked, and also what I asked Nina around asynchronous communication. So like, of course, there's no 24/7, but is there a model around having that access to your provider on your text? Like you can text them or instant message them. And how do you work around that or operationalize it?
Yeah, and I think that Ginger does that. There are a number of companies I think that have that element of being able to text your provider, your therapist, your coach, and really, just to take a step back on that whole systems question. I think that what both Archana and Bambi were talking about around really thinking about the whole workforce and how the term we use is what is it? Practicing to your level, or practicing to your license, practicing to the top of your license, right? So like
yes.
having the right people do the right thing. Ultimately, that's what we need if we're going to scale. And so I really love how, Ginger is approaching that partnership. I think it's awesome. But to answer your question, Archana, I think that there are two things that I'm seeing in this new time of COVID, especially that have come out as a result of COVID. So I work for a chief medical officer for this new women's mental health company called Real that launched about a month ago. And it was going to be in-person studios, sort of like the Wing, but for mental health, where they wanted to have this in-person studio space and for women to be able to go get mental health help in a wide variety of options and think about this demographic specific care model. So not just, how we're delivering it, what we're delivering, and really thinking like in a way that's going to be conducive and personalizing it to women. Then COVID happened, and so everything obviously changed. And over the course of a week, the whole company shifted to now creating an entire digital platform for these services, which launched last month. And what has worked in what we've seen is that there are two things I think that are really important. The first is group therapy. And I think this is something that we talked about earlier with Bambi. And what's awesome about group therapy is that if I tried to organize group therapy before COVID, especially with folks like executives or entrepreneurs, but even anyone from like the busy Stanford students to, the mom who's dropping her kids off at soccer practice, being able to find a set time and set 8 p.m. on Thursdays every week for 12 weeks, the likelihood of everyone making that was like, it was just never going to happen. Honestly, like really never did. And so a lot of people didn't do group because all these barriers were in place that made it like unrealistic for that to be successful. Now it's been amazing that both on the individual front with my individual patients, I think the no-show rate for me used to be at Stanford, we used to be about like 20-25%. Now it's 0. Like everyone makes every appointment. And in real, we have all these groups for women, and it's the same. It's just been like almost everyone has made it. And so that has really changed the ability to do groups. The reason why I think groups are great is that when we look at outcomes, if someone is seeing a one-on-one therapist for 12 weeks versus and they're in a group for 12 weeks, they actually have the same outcomes. So they do just as well. And so again, I was talking before about this bottleneck of the hour, the clinician hour. If 1 hour can treat 12 patients over 1, that's how we're really going to increase access and solve these problems. The second is to the point of async. So this has been something that Real is really focused on around what can we provide people such that no matter where they are, they're going to be able to get care. So almost like Coursera for mental health, they've created a whole set of tools around very specific problems that women might have, like related to trauma or sexuality or relationships or career guidance. And so there's this whole like educational curriculum, as well as the opportunity to interface with your clinician and have these group settings and sessions. And you know, there are worksheets and things like that that you can do online or through an app. So I think what we're really thinking about is when we know that people want to engage in mental health, but there are these barriers around convenience or time or cost, how do we at a very low cost offer these things where there's awesome scientific evidence for why they work and make it really easy for people to use them? And then just the final note I'll make about that is, you know, we are all in a unique environment right now, right? We're at home, like there's no like party I'm trying to go to at you know 9 p.m. on Friday that I need to like worry about getting dressed up for or anything. And so just like because of all of that, we're actually a very like captive audience. I think that's awesome. And what we need to figure out as we return back to the new normal is how do we take the best of that and use that to continue the progress that we've made.
That's a great way to end it, which is sort of what I had in my opening slide, which is in this new normal, who do we become and how do we take the good from this time and bring it forward? So we should end with that, Nina. But I did want to bring Todd in because he's an interesting physician with a number of clinics and hospitals. And I'm wondering, Todd, similar question to Russ, how are you managing what Nina brought up before, which is how are you arming the physicians with AI tools or you know, texting tools? I know Cigna was supposed to be with us, but Eva was supposed to be with us, and Cigna just announced that they did a deal with Talkspace, and one of the reasons why they did that was to have that asynchronous 24/7 texting. So Todd, what are you doing to be able to manage the inflow of patients coming in and either using technology to screen them, some lower level licensure, what are they? Not behavioral therapists before they move on to sort of a psychiatrist. What's the makeup of how you're managing your population, and what are the technologies you're using?
Yeah. First, let me just take 30 seconds to piggyback on one of the things Nina said, which I just want to reinforce because we've had the same experience. It's sort of ironic, you know, we started out with kind of talking about the merits of telehealth in the acute care setting in some of our ICUs with patients in isolation who are COVID positive, because patients would, you know, the only thing you'd see for 7, 10, 14 days was someone coming in your room fully gowned from head to toe and mask and gown and gloves, and it was like you're on a different planet. And that sense of isolationism was just profound. And so being able to see someone on camera was ironically felt much more personal, and you felt more connected. And so we really did encourage that in our acute care settings, distributed, I think, close to 700 iPads for patients to be able to talk to family members if they didn't have a device, or their nurse or clinician. And you extend that to the to the clinic setting beyond that kind of high acuity. And we've seen a similar thing, a lot of the feedback we've gotten. I mean, first of all, our virtual care patient satisfaction scores across the board have always been higher than our in-person patient satisfaction scores. And that trend has continued during this crisis. And one of the things we've heard in feedback is people feel that their provider is much more focused on them. They're not in the room getting interrupted. They're not typing on the computer, or if they are, they're doing it in a way and maintaining eye contact on the camera that makes it feel like you're really paying attention. And I think that has been a fascinating learning opportunity for a lot of our providers to see how much they can connect when you have that one-on-one virtual visit and you're really focused on each other and have their undivided attention. So we've had that experience too. To answer your question, Bambi, with respect to AI and sort of asynchronous tools and things, how are we doing it? My answer would be very candidly, not well enough. I think there's a lot of room for us to improve, and I think it's fertile ground to invest and innovate. But what we do is we, for COVID-19, we developed early on, we developed a chatbot that would allow us to direct people to the right site of care based on, started out with travel history, then we quickly got rid of that as it became irrelevant, and then focused on, things like exposures and symptoms, and directed them either, if super sick, to get immediate care in person or call 911, or not so much, then use one of our virtual tools and talk to a nurse practitioner or provider. On the mental health side, similarly, we've done some tools with surveying our own caregivers around their stress levels across the organization. It's been interesting to see that and track it side by side with the COVID outbreaks from Seattle to Portland to LA and some of our other markets. And then we have very much embraced allied health professionals. We across the spectrum, whether it's in acute care or caring for our own caregivers or ambulatory clinics, use licensed social workers, counselors to be kind of tip of the spear and screen folks with backup by a psychiatrist. And so it is a multidisciplinary care team. And we, as was mentioned before, I think by Russ, this is a supply demand issue, and we're never going to have enough supply. So the more we can invest in using folks that are not physicians to help with that, and then using digital tools. We also have a suite of digital tools that we offer patients to kind of help with that. So multi-pronged, but to say that we're truly doing AI the way I think that we could or should, I think we're just getting started, to be honest with you.
That's great.
You had a short list of where you think you might want to focus on? You can't, like you said, you're not doing enough, and I don't think anybody can do enough, but we can do a couple of things.
Yeah, I mean, for me, it's a lot of what you've already heard. It's going to be chronic disease management and also keeping people out of our facilities, right? So that's where we've seen a large degree of impact. Frankly, a lot of these tools for us are tend to be more used and impactful in a value-based care model. So unfortunately, a lot of the payment structure has a big impact on what you can pilot anything and maybe do a research study, but in terms of doing it at scale, you have to have a model where you either carry the risk or you can partner with a payer to make sure that it's scalable. And so those are I think, as we move forward, again, we've started. Our biggest approach has been our EDs in hospitals and addressing folks in crisis. Then we've moved upstream to try to prevent those ED visits. And in addition to that, we've spent a lot of time thinking about our healthcare providers, largely driven pre-COVID by burnout rates amongst our physicians and nursing staff. That was the original driver for building that program. Now it just happens to be fortunate that we launched it prior to COVID, because it's really helped with that.
It's great.
We have a
And,
question.
you know, as we are coming close to this, go ahead.
Oh, there's a question from Mark.
Yeah,
Yes,
hi.
and Mark is here. Mhm.
Yes, I was just wondering, clearly a lot of the conversation has focused on increasing access. And mine is really about outcomes. So what people are seeing as ways to improve that. Kind of, we know psychotherapy is as effective as medication, but still outcomes are pretty low, with about as 50% dropping out, 25% showing long-term improvement. So interested in the panel's view on ways to improving that.
So Russ, you want to take that first?
Sure. I think part of the goal here is absolutely to drive outcomes, and you know, Ginger to date has seen far higher rates than the standard of care when it's measured. And I think it starts with measurement, and when you track it, you're able to improve it. I think then creating a collaborative care environment where someone is getting instant access to care, they're not waiting weeks to get a provider, they show up to appointments because they're convenient, their telehealth, you know, creates a different element there and ease of getting to their appointments. And, you know, we're seeing 70% improvement rates within 6 to 16 week period that holds longitudinally for 12 months. So we are seeing a very big difference when you apply a different approach to this than what you see historically.
So
Nina?
interesting. Oh, I was just going to add it to that. Russ, because the population that Russ sees is they're really 90% are probably, at least, well, maybe not 90%, but the majority would be on the subclinical level, right? Sort of milder on the spectrum. And I'm curious, what about the outcomes for those who are maybe more severe? And just, does anybody want to comment on that? How are we helping those who are on a sort of a down on a more critical end of the mental health spectrum?
I can address that, and I'm going to unfortunately say what was echoed a little bit ago is I don't know that we're doing that great of a job. I think that also when we look socioeconomically, you know, the folks who are at the Medicaid and, like, you know, that end of the spectrum, similarly, we're not really helping in the way that we need to. So thinking about, like, you know, where do we go from here? Those are the points, I think, that when we can focus both on severe mental illness and you know, what is done for that population, as well as the folks who just don't have the access to resources in the same way. As you know, I don't need to say this, everyone here knows that, you know, when they have mental health struggles, everything else gets that much worse, right? And for the people now who have lost their jobs, maybe lost their health insurance, like, they're already at greater risk for everything. And so things get magnified when it comes to mental health outcomes, and the need to be able to really have access to a whole suite of services. So I think that's our challenge. I think that's what we need to figure out, is how do we do service to these people. One thing I just want to super add quickly about the outcomes, absolutely true, is that we do need to really think about how we improve outcomes, and access is just the first part of that, right? It's first get more people getting the help, and then of course, rather at the same time, make what we have more effective. Measurement is one big part of that I think a lot of folks, and that, in fact, that's how Ginger started off many years ago, is thinking about what are the new things we can measure, how do we measure appropriately and consistently, and how do we use that data and metrics to make better decisions around diagnosis, around treatment, around kind of personalizing you know, medications or treatment. But I do want to say, because I think there is a lot of misconception or, like, misinformation out there, which is that when we look at mental health treatment, the treatments for mental health are actually similar in outcomes to treatments in other diseases. I think that there is a kind of misperception that our treatments work less, or, you know, less frequently. And when we look at actual, like, scientific studies, that's not true. So just want to give a little push out there that, you know, it is actually pretty good, but it absolutely needs to get much better.
Bambi, I can jump in too.
I think there is a yes, go ahead, Naomi.
Oh, I'm sorry. I can jump in too and talk a little bit about the population we see at Brightside, which is a little bit more in the moderately severe category at intake. So we are tackling that sicker population and seeing impressive results using, as Nina mentioned, tools that aren't widely available in care as it exists. That includes measurement-based care. It includes things like a combination of synchronous and asynchronous care. It also includes clinical decision support. So as we assess these conditions, which are very heterogeneous conditions, we can determine exactly what the right treatment for the right patient is. And that we know improves our outcomes tremendously. And you'll hear a little bit more about Brightside in the next panel.
Yeah, absolutely. And I think there is a compliance bias here too, and there's adherence bias there too. So what Mark was asking about, how do you really truly can measure therapy versus prescriptive medications? And I think it is hard to measure because taking a pill is easier than showing up for a therapy session. And I do believe that plane is leveled somewhat with more virtual care. So the access to care, or at least the ease of care, will definitely improve as we go forward. And I know that we are coming close to this session, end of this session, but I wanted to end with two things from each one of you. What's the positive that you're seeing with the COVID aftermath? And then what is it that our innovators can do, one thing that would be uniquely valuable for mental and behavioral health from each one of you? So I'll begin with Russ, because I always pick on you first. You show up on my first screen on the right.
I appreciate that. I couldn't totally hear the first part of the question. Could you repeat that?
Yeah, the first part of the question is, what is the positive that came out of COVID? And then what is it that you want to see get innovated in your space going forward?
Got it. Thank you. Well, on the first one, maybe it's a glass is half full view of the world, but I think there are a lot of positives that we can take away from COVID. I think we are spending more time with our families. I think we are not getting on a plane and traveling as much. We're not using as much fossil fuel as we were using before. I think there's a little bit of a simplicity to life that this has driven. So I think that there are certainly some positives there. As it relates specifically to this world, I think the acceleration of the adoption of telehealth has been something that has brought healthcare forward by years in the last few months. You know, all these solutions were there prior to this period, but people really weren't adopting them at scale, and they are now. And I think that's going to be very sticky because you can get obviously great healthcare at far lower rates and far more scalably through telehealth. So I'm excited about that acceleration. On the second question, what can innovators do? I talk to young entrepreneurs about this. I talk to people who are thinking about going into entrepreneurship, and I would say, do something that matters. There are so many things that you could put your time towards, and there are so many needs in the world. Do something that needs to exist. Do something that if it went away, the world would be less because it went away.
Thank you. Nina.
That was beautiful. I want to take a moment to absorb that. Thank you, Russ. So the good.
It was really good.
Yeah, it was really good. There has been enormous, as I said, silver linings, right? And I stand by that. And I think just more open, more honest, more connected. And the three things I think here, it's stigma, policy, and technology. And I know previous sessions, we've talked a lot more about the policy and technology front. So everyone go listen to some of the past sessions to hear what's been going on. But I think that all three of those areas, the huge changes in policy that have happened that really set the course for our future of actually being different. Technology, where exactly Russ said, it's not new technology, it's how we're using that technology better. And then stigma, it's just really changed the culture and changed the way that we're connecting with each other. So that's what's been awesome. And now we have to use that foundation to think about how to go forward. And then I think, you know, where the real challenge is what Mimi is addressing so well. And I have to do a little shout out to Mimi. Mimi was my first boss when I entered this whole space of mental health technology. And she's been an amazing mentor and inspiration and everything for a very long time. So of course I am going to say that what she's doing is amazing. Treating real disease. And I say that because there are awesome wellness companies out there and a lot of folks who are in the mental health space and are focused on the kind of mild and prevention side. That's super, super important. However, if we look, you know, from the perspective, from the societal perspective, and I keep talking about this, you know, my own background has been more in like political science. I worked on the Obama campaign and now the Biden campaign. And so really thinking about that public health perspective and what do we need as a society, we need the diseases to be treated. And, you know, that's both the types of diseases that are getting treated as well as the severity on any spectrum that's getting treated, because that's what leads to people not living up to their potential, not contributing to society. That's where the enormous costs are, both in healthcare and in terms of just general economic output, period. So I think if we really want to see the changes that this field needs, that like people need, that families need, that communities need, we need to really focus on treating disease. So if you have a new idea, you know, if you're thinking about what to invest in, go to that end of the spectrum and really think about how we can make transformative change there.
Great, thank you. That was really good too. Todd, what is it that you're seeing positive and what is it that we could be doing better on?
Yeah, I mean, with the usual caveat that it took this terrible crisis and pandemic to cause a paradigm shift in how we deliver care. But I think that I would echo what it said already. There are a lot of positives, whether it be fossil fuel emissions or, access to new types of care delivery models. We've seen this explosion in our ecosystem, moving from 70,000 virtual visits a year to over 70,000 a week, and from it's self-serving and unbiased, but I think that's a good thing, and I think that it can improve quality and lower cost, and frankly help transform a system of care that was already clearly broken in this country, and so. So my hope is, and one of the things that we've been focused on and having discussions like this is to spread the word about the value of it and document outcomes and impact of it, and then also frankly lobby HHS and CMS and payers to not roll back. Right, so we can't roll back, and so those are some of the good things I would say. With respect to what we need to do, it's those things I just mentioned. So advocate for keeping this as the new normal, and now that it's gotten people's attention and it's gone from being this niche area that was kind of, oh, that's neat, you're doing telehealth, to actually how we deliver care, we need to significantly improve the experience both on the provider and the patient side. So that automation we talked about, AI, asynchronous communication tools, a lot of the things that we've used haven't really been designed well for that. And so for us, it's trying to figure out that piece for all types of things, from primary care to neurosurgery and everywhere in between. And so that's kind of where our focus is going forward. Don't roll it back, and make it better than ever.
Excellent, thank you. Billy.
Yeah, I mean, people have touched on a lot of it, and we touched on some of those silver linings earlier. I do think that one of the most positive things is the conversation that folks are having around behavioral health is just more and more common, right? There's conversations like this. There's the news articles that are sort of endless about the mental health pain that people are feeling, and that's terrible. But I do think it's forcing the conversation. And it's forcing the people who pay for these services to start to take it more seriously. So that's, as Todd was saying, that's CMS and HHS, that's employers, that's payers.
And I'm seeing that more and more with various companies that payers are saying, hey, we need a network, we need access, we want to we want to provide these services to our populations, and that's great to see. And I think this is sort of a moment that we'll continue to push for it. And it's really sad that that has to come out of so much loss, or other things like school shootings. That's when you hear people talking about mental health. It's sad that that's what it takes, but hopefully we can drive some positive outcomes as a result from it. And as the sort of question of what should people think about, I think it's continuing to think about not just what is the solution that can be offered, but how do we create the business models that are successful as a result of it, where you're really encouraging the payment side of it, because that's how the flywheel starts to flow. It's reducing the stigma, right, is sort of the first thing. It's providing the access and the tools and the solutions. And then it's sort of creating the conversation and demand and showing the outcomes from those solutions to then say, oh, we should pay for that. Okay, now there's more availability, stigma lowers, and that's when things start to really start to flow. So I think that's, you got to complete that circle on the payment piece as well. So, it's a long slog, but it continues to head in the right direction.
It's great. Thank you so much. So with that, Bambi?
Yeah, it's 1:50, so I don't want to keep everyone on here longer than they need to, but quickly on the silver lining. I think I said it earlier, which is this pandemic has taken away what we want and given us this time to pursue what we need. And so we have to think about that. What are our real needs versus our wants? And I think that can change our perspective on our relationships and our life. So just wanted to add that. And now it's 1:50. So we were supposed to end at 1:40. And now we were supposed to go on a break, but I guess people have been going on a break anyway. So we'll just go right into our next segment. And this is when myself and Archana will jump off. We'll still be here, but we'll jump off, and we're going to hand this over to Mark. So Mark, take it.
Thanks so much, Bambi. Thanks, everybody.
Oh,
thanks, everyone.
Thank you. Thank you, panelists, for joining us.
Thank you so much.
Thank you.
That was good. That was really good. Hi, guys. So the next part of the, oh yeah, I think I'm good. The next part of the session is we are going to showcase 4 truly great companies. And I've had the pleasure of talking with all 4 CEOs, one of which I actually know quite well. And they're each going to give a 5-minute story as to why they are different, why they are great, and why you need to pay attention. And, from my perspective, running UCSF Health Hub, mental and behavioral health for our awards contest last year was the #1 category in terms of submissions, which just gives you an indication how much interest and activity there is in this category. We had about 80 different company submissions last year, and we're expecting probably that many this year. So it was the sort of the toughest category to compete in. The winners, the semifinalists, the quarterfinalists were all amazing. And now fast forward, it's almost a year later, and there are 3 companies today that didn't participate in that last year that really have great solutions. So what we're going to do, we're going to kick it off. Each company is going to go through their 5-minute pitch, and then we're going to have I'm going to do some Q&A, and I'll take some questions via the chat, and we'll take it from there. And the first one up is George. Bambi, do you have we're good? I see you appeared again. The first one up is George, and George is actually calling us from Greece, so he's quite tired. So we told him he could get up first. And his solution is really this incredible mental health grade solution around, curing anxiety and depression. And it's an incredible wearable. We know what the Oura Ring has done, and this product can do a lot more. So with that, George, I'm going to turn it over to you.
Thank you very much, Mark. I hope that you can hear me. Without further ado, let me go directly into the presentation. As Mark mentioned, we are Sentio Solutions. We're developing biomarkers and digital therapeutics for mental health. At the core of what we do is objective measurement, as it was mentioned from many of the speakers in the previous panels, in order not only to provide data to clinicians and psychotherapists in order to help them improve their clinical efficiency and effectiveness, but also to use those data to provide real-time support and interventions to individuals that struggle with mental conditions. So what we're doing is using the response of the autonomic nervous system that we're monitoring through our proprietary device as an indicator to extract biomarkers for management or diagnosis of different conditions. So we have already commercialized our biomarkers, our emotion biomarkers for management of mood disorders, and we're working on biomarkers for diagnostic or management purposes for ADHD, burnout, eating disorders, PTSD, and bipolar disorder. So at the core of our solution, we have remote patient monitoring that we are doing through our device. We combine this with telehealth and digital therapeutics. And our very first solution is targeting individuals that suffer from anxiety and depression, as Mark mentioned. So our solution starts from the device that monitors the physiology of individuals 24/7. Based on our proprietary algorithms, we're able to detect the emotional state of the person. And then we're using cognitive behavioral therapy to trigger real-time interventions through AI, through the phone of an individual, or through our care team and our telehealth providers. So at some point during your day, when you're wearing our device, we will detect that you are stressed or angry. We will send you a notification to do a cognitive restructuring exercise, or to do a breathing exercise, or to do a mood journal. And what we've seen is that those real-time interventions that have the goal to prevent ER visits and pre-hospitalizations are actually really engaging for individuals. We see unprecedented engagement of individuals with our program. They spend over 60 minutes per week with our application, and they're performing 15 mental health exercises per week on average. And this is significantly higher from other solutions and other digital health overall solutions. So that's the first advantage, is that we can be right then and there for the user. The second is that we can provide data to our psychotherapists to help them improve their clinical efficiency. So our psychotherapists, based on the data that we give them, they improve their clinical efficiency by 2 times. So they only meet with individuals once a week for 15 minutes instead of 60. And they spend another 15 minutes taking notes, labeling the data, and also preparing for the session. So when someone starts the session with our psychotherapist, they already know what happened during the week. And although we reduce the duration of that session, because we have increased the frequency of interventions, we see significant impact in outcomes. This is a population suffering from moderate primarily and mild depression and anxiety. We saw within a period of 4 months improvement close to 70% in PHQ-9 and G87, and this was without medication. So we made sure that our populations and our data were not skewed by medication. So at the moment, we're working with major health plans in the US. We're focusing on the Medicaid space in the US, which is one of the most vulnerable populations that you mentioned before. And also we're working in Germany with a large health and life insurer there as well. But we wouldn't be able to do any of this without our incredible team. We are based in San Francisco. I'm based in San Francisco usually. I'm now stuck in Greece. I was here to visit our R&D and engineering team in Athens 2 months ago, and I got stuck here since. I hope I'll be able to be back with you guys shortly. You will also meet our VP of Business Development, Kim Warner, shortly after, to answer a few more questions during the Q&A. And we're really grateful to have amazing academic partners like Harvard Medical School, as well as very supportive investors like Felicis. And most importantly, experts and advisors from health and insurance space that are helping us along the way. We're very excited to be here and look forward to connecting with you afterwards, after this meeting. Thank you again very much, Mark and Bambi, for putting this together.
That was absolutely perfect. So if the next 3 companies can do just as well, this is going to go perfectly. Not only were you right on time, it was exactly what we were talking about. That's just a great company. Felice is an amazing investor, and you guys are right on track. Next company is just as great. It's called Emilio Health. Focuses on pediatrics. Naomi Alon is going to be telling us the story, and it's really helping us, all of us, and God knows I've been there with my family, find the right solution, the right therapist at the right time, the right place, but the right problem, and using telehealth. And kids are tricky. And so with that, Naomi, it's all yours.
Awesome. Thank you so much, Mark. Yeah, it's really a joy to get to be here today because Emilio Health is really both a professional and a personal journey. I'm a mom of 3 kids, and one of my kids, for the past couple of years, we've been seeking treatment and getting treatment for him. And it's just been a really broken experience kind of at every turn. So we're here to really create a much better experience for families around pediatric behavioral health. Except that I can't get my screen to progress. Other than that, it's going to be perfect. Give me one sec here. So I think most folks are generally aware of overall conditions around behavioral health, but I think what I want to share today is that pediatric behavioral health, if it's even believable, is even more broken than the adult space. So same need that you see in the adult space, 1 out of 5 kids with a diagnosed condition. Many clinicians think another 1 out of 5 have an undiagnosed condition. Only about 20% of kids receive treatment. And what we're seeing is that year over year, more families are having to go out of network. So Mental Health Parity Act just isn't working. Most of the care delivery today is in kind of single shingle mom and pop solo practices. The spend is growing, and I think one of the most kind of unknown statistics is that there's a family comorbidity. So for families that have any child with any behavioral health need, there is a much higher likelihood that a parent or caregiver will have a behavioral health need. So about 40% greater likelihood of depression amongst the parents and caregivers of kids that have a pediatric behavioral health need. So high comorbidity. You know, why is that? There are even fewer clinicians in the pediatric space. So think about, you know, psychiatrists, psychologists who go through their training have to then get specialized for kids and adolescents. So it's a much smaller pool to draw from. Because so much of medicine is practiced in solo practitioners, quality is just all over the place in terms of the use of measurement, the use of evidence-based protocols, the use of consistent operations in terms of things like medication management. And in fact, we're seeing an increased, a pretty rapid prevalence of use of medications for kids as young as 3 and 4, as not only the first line of treatment, but the only line of treatment. So we're seeing this sort of exacerbation of a medication-only set of protocols without a lot of quality measurement around follow-up care. You know, as a mom of 3 kids, one of my kids was receiving behavioral therapy for anxiety and also occupational therapy support for sensory processing challenges. And nobody was communicating back and forth. Nobody was talking to the school. Nobody was talking to us as the parents or talking to the pediatrician. So care coordination is even kind of more complex because you have a multi-clinician model for many kids. Comorbidity is the norm. And then finally, what we found in a lot of our primary research with families was a lot of parents, and the parents in the room will appreciate this, really want to be involved in understanding their child's treatment plan, understanding how they can actually help support their child's clinical progress. And by and large, clinicians don't systematically involve parents and caregivers because they're not paid to do that work. They don't have the time to do that work. And so there's a huge communication gap for many families around how the family as a structure can help support care and really help their child progress on clinical outcomes. So basically, we took all these broken problems in the system and we worked backwards, and we said, what if we had our dream partner with respect to investors? We got our dream partner with the team at Oak with Billy and Annie, and we put together our dream team in terms of our executive suite. And what if we just redefine the whole experience, soup to nuts? And so that's what we're doing. So think of us as a hybrid model, brick and mortar clinics that feel beautiful when you walk into them. They're appropriate for families and kids. They're modern. We hired the design team that built out the One Medical clinics, combined with telehealth, so delivery of services across the telehealth platform through our app, combined with a coach-delivered tech platform and app. So coaches that help with care coordination and deliver a set of interventions that are personalized to where their child is in their treatment plan. So a really robust kind of three-headed solution. And kind of fundamentally, if you peel back the onion on that, how are we delivering that? So we are hiring a clinical staff of psychiatrists, psychologists, occupational therapists, and speech language pathologists that are working together as one team off of a shared clinical record and a shared set of integrated evidence-based protocols. So what that means is if a child comes to us, if a family comes to us, we do a multidisciplinary intake. We look at what's the right treatment care team to support that child based on clinical measures that they're coming in with, based on treatment history, based on medication needs. And so we really wrap that family around with the right care plan and care team, which means we don't have to deal with a lot of external referrals and wait lists where a psychiatrist may be referring to a psychologist, et cetera. We use evidence-based protocols and treatment plans. And so after every unit of care delivery, whether that's in person in our clinics or through teletherapy, we measure clinical global impressions, we measure treatment progress towards goals, and we communicate that back to families. So they know what to expect in terms of treatment duration, in terms of clinical progress. We refer to ourselves as child-centered, but family focused, which means we treat the children, but we also have a set of tools and capabilities for the parents and the caregivers as well, all delivered through extraordinary technology with an app and a platform that's clinician facing and delivered through a really beautiful set of clinic experiences. And so I'll stop there. I know we're at 6 minutes, but I'm looking forward to the Q&A and talking more with folks. Thank you.
Well, it was a great 6 minutes. So it's completely okay. That's, I'll get to it later. This is also near and dear to my heart because of some experiences I've gotten with my family. And I just can't believe that these types of services are coming to market and the pain and suffering that we went through. So, you know, this is truly great. This is truly exciting. Mimi, you're next. So Mimi's going to talk about Brightside. Brightside's a bit more of a classic take. You know, it's not focused on pediatrics. It's not a piece of hardware that we're through telehealth and medication therapy, but they seem like they've got some really great traction. Mimi's a firehouse. So Mimi, it's all yours.
Can you guys hear me?
Yes, we can hear you.
Yeah, thanks for having us.
There you go.
Great, thanks for having us, Mark and Bambi. And as you know, I won't spend a lot of time on the scope of the problem because we've been hearing about it from so many people today, but anxiety and depression, which is what Brightside is aiming to treat. We're direct to consumer digital mental health company to treat depression and anxiety. And we try to meet, as Nina was saying, meet people where they are. But we do know the scope of the problem is huge right now. A recent census is just showing, you know, since this COVID crisis, that 30% of Americans have meet criteria for diagnosis of generalized anxiety disorder, and full 24% meet criteria for major depressive disorder right now. So this is an enormous problem. We also know that 13% of the US population is on antidepressants right now, and that's 68% of those are on them for 2 years or more. I know in the survey comments, there's a lot of concern about how these conditions are being treated and are they being treated correctly, you know, with pharmacologic agents only. I think one thing to note is, you know, to Naomi's point, when we consider that 13% of the US is on antidepressants, if we exclude children, we know that a lot of, even more adults, even a larger percentage of adults are on antidepressants. And most of these folks are getting care through their primary care physician. And primary care physicians are very well intentioned, but they do not necessarily have the tools or the time to treat these conditions. We also know that a lot of Americans are interested in therapy, particularly millennials. 21% are engaging in therapy at this time. So I'm also having trouble advancing my slides. How did you guys manage to do this?
I think it might be a
I had to
bandwidth.
take it off of presentation sharing mode.
Bandwidth.
Oh, there we go. I got it. Okay, so telemedicine is now the only game in town. So, you know, having the important tools in place to deliver high quality care to patients who need it is very important, and Brightside has built these tools. I'll go over exactly sort of what we've built that particularly addresses the telehealth problem. But I think a key factor is that we're not just taking a physician and a patient and putting them behind a camera, you know, because I think that is telemedicine 1.0. It's what's been practiced up until now. And we know that to be effective, telemedicine has to do a lot more than that. It has to incorporate a lot of other digital tools that have been spoken about today, but those include measurement-based care. They include a combination of asynchronous and synchronous tools, and we'll look at how Brightside's doing this. And this slide just is to say people are desperate for these kind of tools, and physicians are desperate for these kind of tools. Therapists are desperate for these kind of tools. So we're using our technology to actually enable the physicians to deliver the care they want to be able to deliver. We have two arms of our business. We have an RX, that is to say a medication side of the business where we treat psychiatry patients. So they are getting an assessment by a physician and medication. And then we have a therapy arm of the business where there's not necessarily medication involved, although patients can sign up for both. On the RX side, patients go through an elaborate intake. We collect over 100 data points on them. They're given feedback on their assessment. They can meet with a doctor. They do meet with a doctor over video. They come up with a collaborative treatment program, which includes measurement-based care to follow them, unlimited text messaging with their physician, and additional video visits. This is all for a low monthly fee that they can pay. So we're able to address the care from multiple modalities and remotely monitor the patient, as well as adjust the treatment as needed and see the patient just in time. On the therapy end, you can see that patients also get access to self-care tools, audio modules, learning tools where they can engage in exercises, but then they can also engage in unlimited texting with their therapist and meet with a therapist over video. We're also using those same remote monitoring tools that we've include clinically validated tools like the PHQ-9 and GAD-7, but other proprietary tools to track the patient's progress so that we know how they're doing, whether care is progressing according to the standards that we would hold them to, and know if they need additional follow-up visits. Again, we've designed these particular tools because they don't exist in the world right now in the way that care is delivered, mental health care is delivered. So as a result, we've designed our own EMR, which encourages intuitive decision-making on part of the providers. Providers are also given a rule-driven workflow so that they can always see how they can deliver that care both asynchronously and synchronously per their decision. We've also incorporated clinical decision support into our platform. So as we've collected hundreds of data points on any given patient, we're able to determine what the right care plan for them is based on our large data set. So we know depression, as I said, and anxiety it's not a homogeneous condition, it's a heterogeneous condition. There are many forms of depression. It can present clinically in many different ways. So what we've got now is a series of attributes, a series of treatments, and a series of outcomes that we've plugged into our system. We're now sitting on a very large data set as we've treated thousands and thousands of patients. And we're able to use this to determine a machine-based learning clinical algorithm that guides the provider into what treatment would be best for this particular patient. So each patient's subjected to a set of logic and rules, and then the MD reviews that and then adjusts the treatment accordingly. Our results speak for themselves. 100% of our patients get care consistent with best practices. And it's worth noting that our patients do not have mild illness. Our average PHQ-9 score at entry is 19.5. That's just shy of severe. So 66% of our patients come in with moderately severe to severe symptoms at the outset. And we're seeing clinically significant symptom reduction in 12 weeks among 83% of them. So 83% are getting better in 12 weeks. You can also see our average score goes from 19.6 down into the mild range at 12 weeks. So tremendous results that are just, actually not comparable to what one sees in clinical trials. And we attribute this to the fact that patients are getting care at the right time. They're getting the right kind of care based on our clinical algorithms, and they're able to engage with the system, stay engaged, seeing their results progress. Patients are giving us reviews. You just go to our webpage and look at our review page, and you can see that people are telling us to be a part of this company. And we're now live in 82% of the country and growing very rapidly. We've seen a tremendous surge in engagement so 50% growth in first quarter, and now it's like 50% growth sort of honestly every few weeks. It's the COVID crisis has really sort of been for better or worse, a big tailwind for our business. There are a lot of people in need right now. But thank you again for letting us present.
Great. Mimi, great job. I didn't realize that you have Tom Spann, who is my fraternity brother, my actually big brother from my fraternity, as your partner. Congratulations on him. He is incredible.
Yeah.
And look, here you have there was a company, it's evolving, it's growing. It's sort of what I call being sort of on the right side of COVID. And what an exciting story Brightside has become. Next is InCare brand. And Pam is going to show you a different type of company. It's a compression garment, it's a vest. And what they do, they're going to explain the importance of compression, but I'm not wearing this because I just felt like I wasn't cold, because you can't get really cold today in SF. I'm wearing this because I understand the problem. And the problem at our house is we've had our kids wearing this when they were younger, wearing compression garment. And their approach to it is absolutely genius. So with that, Pam, it's all you.
Great, thank you. Thank you for having us. We're gonna share our screen right now. Okay. Sorry, give us a second.
Can you guys see this?
Yes, we can see you.
Okay, great.
Awesome.
Amazing. Okay. Hi, I'm Pamela. This is Michael. We're the co-founders of InCare. We make therapeutic wearables for people with neurological differences, autism, brain trauma, and mood disorder. Our goal is to make a service that empowers people to help them manage themselves independently. So we all know the statistics that we've been talking about all day, and we see that now is more of a pressing matter because everyone's isolated and alone. And we're really narrowing down on people who have autism because they're not getting the treatment that they deserve, especially into adulthood. And our solution to this problem is to make an integrative system where we combine hardware and software to make a tactile approach. So we have a smart compression vest that uses clinically proven deep pressure touch to help people self-regulate on the go, and an app that connects to the wearable device.
And here you can see our working prototype that we've developed over the last few months. And what makes it special, it's really intuitive. You can actually inflate those air pockets by a self-hugging gesture control or by a connected smartphone app. Our product is also smart. We are planning to collect biometric data, so you can even inflate the vest automatically based on stress level, heart rate, and similar data.
And then what makes this difference is that we're collecting this data so you can share it with your caretakers or loved ones. And we're making these skills where you can learn on the platform, and we're also helping you self-regulate instantly.
So here you can really see what our product is all about. We have those micro-inflatable air pockets embedded into the fabric, and those can be activated and filled with air automatically with a self-hugging gesture like this, or with a connected smartphone app. And what really enables our product is the smart inflation unit that we have developed. It's very, very small. It fits into the pocket. It's battery powered, and it connects to your smartphone via Bluetooth. And here you can see our first working app demo. So we have integrated a few relaxation exercises that you can see on the screen right now that further amplify the effect of deep pressure touch and that help you to focus on the moment. We're also integrating skill building exercises, and we are planning to connect to therapists, doctors, and other people with similar symptoms so you can build a support group. Here are a few more slides of our app. You can even set up your own like activation points for the gesture control. You can enter your symptoms. The slide 3 shows our relaxation exercise. On the slide on the right-hand side, you can see our custom pressure programs that you can add and that you can share with other people as well.
And then we're really big on the social aspect. So we're making a network where you can reach out to other people, or you can send hugs to loved ones, and you can send that data to your doctors. And we're trying to be interval. So when therapists can't be there for their patient, this vest can help them relieve their stress or what they're going through in between sessions.
And here you can see the competitive landscape of the product. So the deep pressure touch technology is a clinically proven principle, and it's used in existing products on the market. We are really bringing this technology to the next level and making it smart and more user-friendly. So most of the products, they are very bulky. They have a manual air pump that you have to inflate manually. You can't really use them on the go, only at home. And they only provide a quite small user value at a high price. So what we are trying to do is to develop a compression vest that is smart, inconspicuous. You can use it on the go, and we are planning to offer it at a competitive price point of about $250 to $300 US, and our cost of goods is about $60 US.
And everyone uses this with their weighted blanket at home. So we're just optimizing it. So this is a product comparison. This is what's in the market right now, Snug Vest, and it retails for $312, but you have to manually pump it with a big pump. And our kind of niche market is that we're lower price, and we are like the jacket can snap into outer jackets. It's fashionable, it's comfortable to wear, and you don't look like you have like a disorder. Yeah, it's not stigmatizing. And then our business model is we're gonna have a one-time fee of $300 and a $10 a month app subscription to health providers so they can check in on their patients. And then our go-to-market strategy is to make meaningful connections with therapists, psychiatrists, occupational therapists, specialty schools, and hospitals. And we also plan to sell it directly to the consumer since we are cheaper. And this is our team. I'm Pamela. My background's in fashion, more specifically design for disability. And Michael is an engineer and industrial designer. And these are our advisors. And thank you. We're InCare. We're here for you. Please check out our website if you want to pre-order a vest, and email me if you have a question. Thank you so much.
Thank you, guys.
That's great. This is going to be a really great product when it comes to market. And you know, you guys should be really proud of all the work you've done so far. Our last presenter is actually, I'm an investor in the company, so I have to, it's important that I say that. Chris runs a company called NeuroFlow, and NeuroFlow is different. NeuroFlow is not focusing on pediatrics, not focusing on tradition, you know, a lot of the traditional things that we think about in mental health, but is more focused on the therapists within organizations and basically building them tools so that they can do a better job working with more patients. And with that, I'm not going to steal Chris's fire. Chris, it's all you.
Thanks, Mark. I appreciate it. Thanks, Mark and Bambi, for having us both and inviting me to join today. So, you know, basically Mark said it well. We're promoting measurement-based care and collaborative care. And we're using technology to bridge the divide with mental health specialists in healthcare systems. So in a lot of use cases, we're used in physical healthcare settings with primary care providers, pain management providers, and so forth. we're doing it, I'd love to tell a little bit of my story of where and how I ended up here, and why the bridge between mental and physical health is so important. So I served in the Army for 6 years, a huge honor in my life, deployed overseas, and long story short, I lost a soldier to depression. He took his own life, and when we did an investigation of what happened, he was being seen for physical injuries, like many of us were, and he was also screened for depression and PTSD, was screened positively, and which is good news, right? Because now he's identified, and he was then referred to a behavioral health specialist. And fortunately, that behavioral health specialist was co-located with the primary care doctor that referred him. There was a pharmacy right in the same location for his antidepressants, and 3 months went by, and we learned after the fact that not once did he go see his behavioral health specialist, not once did he fill his antidepressants, and not once did his care team or providers follow up and measure his progress over time. And and that's why I put that as my biggest leadership failure to date, and that's what drives my passion with what we do. But unfortunately, he's really more of the rule than the exception here. And so we're pretty proud. In a little over 3 years, we've partnered with now 150 systems and providers, and we have 250,000 patients being supported now, and have a little over $12 million in investment. And we're doing this because there's really good news. I mean, I'm so glad it was talked about earlier in the panel that there are treatments that work. They really are evidence-based platforms that work. The challenging stuff is that most of the people that need the care don't ever follow up with the care. Behavioral health specialists are, there's a tremendous shortage of behavioral health specialists. There's a stigma associated with it. Cost is an issue. Yet we know a majority of the people that need BH issues see a physical health provider. And so what does this actually create, right? It's inconsistent treatment with primary care providers, over demand, especially today with COVID-19, telehealth services are tremendously important, but the wait times have gone from minutes to days sometimes because they're just overutilized. And so we think about the way that we can reduce this friction by providing real-time resources to patients, but not just apps that aren't dynamic, but apps that really feed back to the clinicians, both the therapists and the physical healthcare providers. Again, bridging that divide so that you can effectively triage the patients and when it comes down to it, augmenting their the continuum of care, right? Not replacing the doctors here, but taking what is already proven, what they know is the right clinical decisions, and expanding their reach to those patients. And that's what NeuroFlow is the technology platform that enables that, that collaborative care element throughout the health systems, from primary care provider to behavioral health specialists, improving the way that these providers treat their patients, and the size of their patient panels, right? Effectively being able to see more patients in a more continuous fashion without more resources. And so we do this with, three major ways. We talked about measuring outcomes. There's the PHQ-9, the GAD-7, there's a slew of other evidence-based validated assessments for a variety of different issues, all that could be digitally tracked more longitudinally than just the once a year when they come in for their appointment. Measuring is half the battle, then the other half is, well, what do you, I should say measuring is a third of the battle, then the other third is, well, what do you do with that measurement? So helping them with decision supports, what are the clinical guidelines say and recommend, and then motivating those patients to stay adherent, to be engaged. And this, when you put all those pieces together, that really makes what this is known as the psychiatric collaborative care model. A psychiatric collaborative care model, this is from the University of Washington Ames Center, is, it is very evidence-based. Decades of research to prove that it improves outcomes and reduces the cost of care. as you can see, that there's a lot of moving pieces. It's complicated, very expensive to hire all those people. And so that's where we think technology could come in. And we've proven that having a technology layer to assist those providers to augment them and expand their reach not only improves outcomes and reduce the cost of care, but does so in a more cost-efficient way. And effectively using that data, we could then more cost-efficiently triage the patients, giving the right patients to the right type of care provider at the right time. I'll wrap up with, I mean, the data speaks for itself. We're not reinventing the wheel using new therapy protocols. We're not using new guidelines or new assessment data. We've created a tool to augment and allow these providers to treat the whole patient because it's about time that, you know, mental health is health. And when you affect one, you positively affect the other. And you see it in not only the improved outcomes, but fortunately, policy shifts are occurring too with new CPT codes. You know, primary care providers, MDs can actually get reimbursed more for doing this sort of work and remote monitoring piece of things. So again, thanks for the opportunity. It's great to be here today.
Excellent. Chris, great job. So Chris is a very different type of company. It's really, he goes into hospital systems and basically gives a workflow platform so they can basically manage and treat, you know, treat their more patients more cost effectively. I'm going to get into some Q&A right now. Bambi, give me a, what's a time check? How much time do we have for this?
10 minutes, I believe.
Excellent.
Yep.
Okay, good. All right, I'm going to throw a few questions out, but I'd like everyone out there to use the chat system and put your, you know, give me the questions. I'd just assume ask those. And let's have spend the next 10 minutes doing this. So I'm going to start, Pam. I'm going to start with, I'm going to start with you. So hardware is hard. This is going to be a hard business. Tell me about it and tell me why where are you going to raise the money and what's the game plan?
So yeah, hardware is very hard. We're actually bootstrapping it right now. We're looking at getting into different accelerators to help us kind of scale up our MVP and test the product more.
Yeah, I mean, like what you mentioned, hardware is super hard. I mean, so far we've been self-funded all the way.
Mm-hmm.
We've invested about like 20,000 out of our own pocket so far. But we've been like lately we've been accepted into a few accelerator programs that we can choose from, and I think that will really help us. And besides that, we also are part of this incubator program already in Brooklyn called Collab, which is helping us to get partnerships.
Great. So if anyone is here on this webinar is an investor, they should contact you. No question.
Definitely, that would be awesome.
Please.
Good. Well, that sounds.
I just have one quick question. Did you consider? I think this is a great product. As a clinician, I feel like. But how do you wash it? Like, is it launderable, or like how does it work from operationalized perspective? Did you go through reimbursement model and things that you've built in the workflow? So the patient workflow, the provider workflow, and then how would you pay for it? Did you look at that?
We're like right now we're still at the MVP product, so we're going to look at FDA approval, but we don't really need FDA because there's already products that are out there with this that's using this that aren't FDA approved, and they are in hospital settings. But so for washing it, you just unplug the tube and you throw it in. We have other competitors where it's like a whole system of washing it and you have to just like wipe it. But ours is like a normal down jacket, so you can just throw it in the wash.
Okay.
I suggest not to try.
I just want to give some time to some of the other.
Yeah.
Interesting.
I'm gonna shift it over to Naomi. So how many of these can you open up? I could see every city in America having one. Is it sort of like a Weight Watchers for mental health for kids? Tell us more.
Yeah, I mean, I think the reality is we'll know a lot more a year from now, but the intent is to be able to open, at scale 20 a year, with the idea being that you have a showcase brick and mortar clinic and a smaller set of clinics and given metropolitan statistical area. But the reason why I pause is because we're really all collectively as we do believe that our telehealth market entry strategy will be a very likely strategy that we go into new markets with a telehealth first solution while we're building out the brick and mortar presence, in which case the rollout could be even much faster than that. I think very fortunately for us, the light bulb has, I think, gone off in terms of a handful of strategic health plans really realizing the total network inadequacy. So, from a demand perspective, I think we're kind of not really limited there at all. It's really how rapidly we can launch a new development to support the new markets.
Nice. Mimi, got a question for you. What amazing progress at Brightside. It hit me when you were presenting that I saw a version of your deck 2 or 3 years ago, and you have.
It's been 3 because we didn't exist. So that's how fast we're progressing. The company's about.
This is it's incredible how you guys have figured it out. So tell me, what do most therapists think about what you're doing when you tell them? Tell me what the what the feedback is from the traditional community.
Well, what's been interesting about the last few months is the outpouring of requests that we've seen, not just from patients, but from providers. Everybody wants to work for us right now. And so I think that sort of speaks for itself. But why do they want to work for us? They understand that telehealth is probably the better and safer way to practice right now, just for their own well-being. But I think when they see our platform and they see our tools and they realize how intuitive it is to use and how they can manage actually a larger patient panel than they would just seeing people in a kind of face-to-face way, even if that's over telehealth. So just, again, putting people behind a video camera solves some problems, but it doesn't solve others. And I think anybody who's been in practice for any length of time, and I've been in practice 25 years now, so I have seen firsthand how broken the system is, all the ways that, Naomi and others have described. And, you don't have to have it affect your own family, I think, to see how broken it is. But it affects the providers as well. They want to be doing a good job. They want access to tools like remote patient monitoring. They want to be able to deliver some of the care asynchronously, and getting those tools on their own is really tough. We've had to build them from scratch. And so they love it, is the short answer. Our doctors love it. Our therapists love it.
That's nice. So what you're saying is originally you weren't thinking so much about that aspect, which is the augment aspect, until all of a sudden it became COVID hit. And you realized that, wow, you had really built an incredibly evolved product at the right place at the right time.
We knew our product was evolved. I think we've always seen the shortage of providers, particularly psychiatrists, as being a bottleneck in the system. And that bottleneck has opened wide up right now because I think providers are welcoming these tools to incorporate into the way they're delivering care. And so, it's what's interesting is something that we saw was going to be a big challenge, which was how do we get enough providers? Suddenly, now is like it's growing at the same rate as our patient population.
Chris, I'm going to turn it over to you. Now, your focus is a lot of larger health systems. You have quite a few VAs using it. Why don't you talk about the VA and as it relates to how they're augmenting in their practice?
Yeah, for sure. We're not delivering care, right? NeuroFlow is augmenting their ability to deliver care. So the VA has invested a bunch pre-COVID having telehealth infrastructure, telehealth hubs, and effectively what happens after COVID is every appointment moves to being remote, and they just didn't have the capacity for it. And so using a technology to remote monitor and engage patients in an asynchronous manner using data to risk stratify them, enables them to get the right patients, the right type of care when they need it. And then integrating that BH component across the care continuum, therefore effectively enabling them to get more bang for their buck, if you will, from their telehealth investments, because they're the ones, again, providing the care. We're just augmenting their ability to do that using data and patient engagement tools.
Great.
There's 2 questions in the Q&A.
Excellent. Well,
or 3.
Good.
Yeah, we have, I think they want to ask live. I think Mitul is
great
on, and then Matthew is on too.
Great. Okay, well, go ahead, guys. I don't have to be your mouthpiece.
Mitul, do you want to ask the question?
Yeah, sure. Can you hear me? Great. So, hi, this is for Naomi. I really love what you guys are doing at Emilio. I've been following kind of your progress and admire what you're doing. I had a question specifically about your approach of proactively including family and caregivers in the care plan and how open providers have been to that approach.
Yeah, thanks, Mitchell, for the question. By providers, you mean our clinicians on our team, or do you mean outside providers, primary care adults?
Outside providers, yeah.
Yeah, we've actually been, I would say we've been provider response, and I think they will say unreservedly that they're not staffed or reimbursed to be frontline behavioral health care screeners, or certainly not screening or really treatment providers. And so, what we've been delighted by, we've been in conversations with kind of the who's who of the academic medical centers across the country. And with to a T, all of them have said, if you literally were to set up a clinic right across the street from us, we would have more referrals to send you than we could ever imagine. We were just, at that sort of a rate limited capacity. And I think it's, I think that the promise and are prepared to know what questions to ask and follow-up care has been tremendous. So the idea of we're not just supporting live and telehealth treatment, but we'll also have a coach that's family facing that supports care coordination and helps families understand their, I'd say for us, we are working on early ideation of what a deeper collaborative care model would look like with a handful of academic medical centers. Because we have a coach model in addition to our clinician team, we are toying with the concept of, do we actually do some co-location of our coaches? So we actually are deeply integrated in with some primary cares across the country. So there's a number of sort of care collaboration models that we're working through, but overwhelmingly positive is the short answer.
Great. There's some more questions. Who else wants to go?
This is Matthew Holt. I'm obviously going to ask Naomi why she hasn't been round to my house to pick up my daughter as we agreed. No, that's not the question.
COVID-19, man, COVID-19.
So accepting, I think, Naomi and Pamela, probably, and maybe Chris for NeuroFlow. This is the why you guys question. So there's been, just in the past week, Mindstone pulled down 100 million. Early this year, Lyra pulled down, it was 200 million. There has been a ton of money gone into this space. And not to mention the fact that Livongo's got a version of this, Amala's got a version of this, Teladoc's got a version of this, except, Talkspace has got to have many hundred million. Some private equity firm put 1.2 billion into, God, I can't remember the company. Anyway, at some point, don't we have enough online mental health behavior therapy companies? And how do you make sure that you guys make it? Or, what is so different? Because, we see the rest of these markets starting to consolidate. Why do you guys make it? That's probably for both me and David and Kim or everybody else. And I may not be asking this question. I may not be asking this question very epidemiologically.
I can speak a little bit to that. I mean, I think that there's this notion that depression care is a commodity, and it's just something that you can provide easily if you have a company designed to administer a PHQ-9 and a GAD-7. And I would strongly disagree with that notion that, you know, treating these patients is serious business. It's a risky business. They're sick, they can kill themselves. And you have to have really good tools to effectively manage these patients over telehealth. And I don't think every company, and I'm not, you know, pointing any fingers at all, but I don't think every company that's gone into this space has thought that through as carefully, certainly, as we have, in terms of building out all these tools. Like I said, we've built our own EMR. We've developed workflows that ping the provider exactly at the right time so that they need to look at the patient exactly at the right time. And this is, I think, where telemedicine can exceed what's happening in current standard of care, particularly as many of these cases are managed by their primary care doctors who don't have the training or the tools to manage them. So I would say that what distinguishes the good companies from the not so good companies is a more sophisticated approach to the care. That means not looking at it as a commodity, treating the conditions as the heterogeneous conditions that they are, and building the appropriate tools to deal with them over telemedicine.
So you're better, is the answer.
Yeah.
That's why you survive. Okay.
I'll ask a next question. Hello, can you hear me?
Yeah, but before you jump in,
I'll answer that question though.
Yeah.
Oh, sorry.
Likewise.
Yeah, yeah. Sorry, Bert. So Matthew, thank you for the question. I mean, I echo a lot of what Mimi said. I would say, I mean, Sentio Solutions is definitely differentiated in the point that we're the only company with a sensor that actually detects emotion, and we're not revolutionizing the actual, you know, the mental health solution in its entirety. We're leveraging proven cognitive behavioral therapy. So our influence and our innovation is really around acknowledgement of an emotion and being able to capture that in real time, so that when the individual does meet with their therapist on a weekly basis, that they're talking about very specific emotions that happened at that moment. So we're nudging them and notifying them that they've actually had an emotion, and to please log it in you know, 5 quick questions. And this is feed for discussion with the therapist. I mean, cognitive behavioral therapy, we are just leveraging the science behind cognitive behavioral therapy. And it was talked about earlier about, you know, our all of us have, you know, kind of this maladaptive thinking, and so we're just finding new ways to be able to increase the efficacy around the cognitive behavioral therapy that exists currently between the therapist and the patient.
Anyone else want to answer this one?
Yeah, Mark, thank you. I'll jump in. This is Chris with NeuroFlow. It's a good question, Matthew, and I think the bottom line is that the companies that you listed out are all providing care. They're treatment providers, or they're therapeutics. NeuroFlow is not claiming to be that. We are a workflow tool to enable the care providers to deliver better care and to stay connected with their patients, to deliver evidence-based care. So it's not a question of being better or not better. It's different. And we're really a workflow and augment tool for the providers that are delivering care.
Great. Any other questions? I knew there was one before.
Hi, I'll ask. So this is, I guess, for everyone, but specifically for that startup. I can't remember the name, I'm sorry, but that gathers physiological data to do diagnosis and suggest solution. So I think there are mainly 2 potential risks. So first, when it comes to hardware of gathering the data, as well as second, algorithms to analyze and do diagnosis. So first, when it comes to hardware of gathering data, I don't know if we are there yet where we can gather accurate data. So the risk here is accuracy of the data collected. And like a little personal anecdote is I've used few of the wellness watches that's out in the market already. And one of them has this stress measure where they kind of flag whenever I'm stressed out above the threshold, and they suggest like a breathing exercise. And there are a lot of times, like more than 50% of times where I'm not stressed out, but the watch is telling me that I'm stressed out. So I need to do breathing exercise. So I start losing trust as a user, right? So do you think that we have the hardware? Like, do you have the hardware that can accurately measure the data? So that's my first question. So the second question is, when it comes to algorithm, how can we ensure that the algorithms are equitable? Because there are few privileged humans, either software engineers or the physicians, who will be chosen to input logic into the algorithm in your software, right? So how can we make sure that the logic is that makes sense for everyone, not just for few people?
Why don't we jump on the false positive question? I think that's a great one. Who wants to hit that one?
The false, her first question, Mark.
Yeah.
Yeah. So Bora, yeah, I can appreciate the question about the wearables and collecting the data, and I think there's a lot of companies that are claiming to be able to detect stress based on maybe just heart rate, and I think that's probably or heart rate and maybe one other sensor. And so there's a difference between being able to identify stress versus what Sentio solutions, and forgive me, I'm pitching in for George. George was the one who did the presentation. I'm Kim. I'm jumping in for him since it's 1 o'clock in the morning in Greece. But that's not what we're doing. We are detecting emotions based on all of the sensors that we have, which are much more sophisticated. And this kind of goes to Matthew's earlier question about why will we still be around? I mean, we are at the earliest stages. I was with Fitbit when they started, and we are at the earliest stages of collecting data around emotional sets. And nobody else is doing this out in the commercial landscape right now. And so the possibilities are endless. And as far as the false negatives, the humans are our gold standard. So we present to the human when you have an emotion, and 90% of the notifications that we provide to humans, and we've tested this on 500 individuals in a study, 90% of the emotions that we prompted were accepted as true emotions. So I'm happy to answer any more questions outside of this.
That's great. So with that, I think it's time for us to thank our startups and a fascinating landscape of hardware to software to dashboards like NeuroFlow and treating critical medical conditions like depression and anxiety. So thank you so much for all of you to be here with us, and also addressing a very big need of addressing kids. And I think that's where mental conditions start. And so thank you, Naomi, for that element of this. So, and then also all the people who were asking questions. So Bambi, are we ready for the second session?
Ready for the second session. And thank you, Mark.
Thank you, Mark, for joining us in moderating this.
And everyone is welcome to stay for our final hour and participate as well in the conversation. It's so much nicer to have just everyone interact and engage, because you're also very smart and understand the ecosystem well. So feel free to stick around and let us know, put your questions in the Q&A or ask in the chat, and we'll get to you. But let's go ahead and get our panelists on for the second one. I see David's right there. So
yes, Alex is there too. I see Alex and David.
Who do we have? We have Brian.
Brian is here too. Perfect.
Great. And again, thank you to all the startups, and hopefully we'll be able to, if anyone's interested in connecting with them, let us know, let me or Archana know, and we'll try to make that connection with them. Or just, again, stick around and be part of the conversation. So let's go ahead, and we have our panelists here. We have, although no, we have a chair, and that would be Alex, I guess.
Yes.
Back. And there's Alon, and there's David.
There's Alon. Okay.
Brian.
Brian.
And so I think for those who, I don't know how many people came to our prior salons. So we want everyone to introduce themselves again to this this audience. I'm sure we have the same folks, some overlap in the audience, but for those who aren't familiar with what you guys do, please go ahead and introduce yourselves, and also give a little bit of background, what you did prior to your current position.
Absolutely. And so maybe we can begin with Alex. He is on the top of the list here on the right side. So Alex, can you introduce yourself?
Hello, my name, can you hear me?
Absolutely.
Perfect. Hi, my name is Alex Morgan. I am a partner at Khosla Ventures. We invest broadly in a range of areas with the vision of societal improvement through technology. And for us, that's everything from investments in space and rocketry through to sustainable agriculture. We're seed investors in Impossible Foods, and we did that as a clean tech investment. But a big part of what we do is healthcare and biotech, and I'm involved in a decent amount of our practice there. I am originally by training an MD PhD, and have done a lot of work in computational biology and machine learning and in medicine and other biological applications. Worked in a lot of startups in space and diagnostics, digital health, and we are still actively investing, I guess I should add. We've done a handful of investments in the post-shelter-in-place world, and so I've led 3 so far, and it's kind of been an interesting experience because I've invested with 3 teams that I've never met in person, and we did all our diligence and all our work remotely. So let me finish up with that. Thanks.
Excellent. Thank you, Alex. And David, you're next on our screen. So can you share something about yourself and what you do in your day job?
Sure. Hi, everyone. My name is David Bond, and I'm in San Diego, California. I'm a licensed clinical social worker. I've been a social worker for a little over 20 years, and about the first half of my career was as a clinician, a trauma specialist, largely for children and adolescents, and then I had a small private practice where I worked with adults who had been combat deployed or who had experienced community violence, and I also worked with incarcerated youth. Then I moved into administration, and I did hospital administration in a children's hospital for a number of years, and then moved into my next most previous job. I was the clinical vice president for National Suicide Prevention Organization for LGBTQ youth. And now I'm at Blue Shield of California, and I'm the director for behavioral health and responsible for Medi-Cal and Medicare recipients.
Great. Welcome. Brian, you're up next.
Sure. Thanks for having me. I'm Brian Garrett. I'm a co-founder of a seed stage fund called Crosscut Ventures, based in Los Angeles. I've been a venture investor for 20 years now. Moved back to Los Angeles after being in Silicon Valley for 10 years in 2001, after the original bubble burst, and started Crosscut with 2 other partners in 2008. We're national in focus, invest anywhere, and in particular, our interest in what I would call broadly healthcare tech, really started around LA becoming sort of an epicenter of innovation. And I hired a colleague of mine, Maureen, out of Cedars-Sinai to kind of lead our efforts there. So we're a broad technology-focused seed stage fund, but with a slight bend on some of these topics that we're discussing today. I think also the reason maybe Bambi invited me is I've been pretty vocal on mental health efforts around founders in the entrepreneurial community, and have announced some programs there on how Crosscut wants to work with founders to help them navigate what we call the entrepreneurial journey.
Thank you. And Alon, you've been a participant with us for a while. We know you well, but can you introduce yourself to the audience, please? You're on mute.
I'll make it quick. So my name is Alon. I'm the founder and president of BetterHelp. I'm an entrepreneur. This is my 4th startup. The first one in the health sector, so not coming from this domain. BetterHelp is the world's largest online counseling platform. We connect people looking for mental help with their mental health to licensed therapists. We have a network of close to 10,000 licensed therapists nationwide. We're 100 people in Silicon Valley. We got acquired by Teladoc in 2015. And we're predominantly a direct-to-consumer play. So people pay for their own mental health to work with a counselor, either through a messaging, video, phone, or chat. In terms of finance, we disclosed that our revenue are over $100 million and increasing by 50% or more year over year. That's us.
So let me jump in. Brian, you mentioned something. I was actually going to go to Alex, but Brian, you talked about founders and maybe having pre-COVID having an interest in their mental well-being already pre-COVID. We had an interesting discussion in our last segment where Russ Glass from Ginger talked about an increased number of males starting to raise their hand and share that they are suffering from some mental illness. And predominantly it's women who are more open about this. And so we had an interesting discussion that's never come up before, but Dr. Vasan also mentioned that she's starting to see an increase in males as well. And she treats a lot of founders, and perhaps it's because there's more male founders. But do you see that the male founders are having a more difficult time than the female founders getting through this? And how are you supporting your portfolio companies?
Yeah, I wouldn't say I've seen a greater proportion of male founders. What I think I would observe is maybe the stigma of acknowledging that you need help is diminishing in the entrepreneurial community, and those that had the belief that the chest pumping framework of I'm killing it when they're really not killing it, that it's okay to let that facade go. And that's just a changing culture across the entire entrepreneurial landscape. I think it tends to have a greater impact on male entrepreneurs because they're not as, well, let's just say female entrepreneurs are maybe less caught up in their ego. So I've seen a dramatic increase in the willingness to go there, which I did not see in the first 18 years of my venture career. I would also acknowledge that there's a self-selection bias in that when I put myself out there as someone that wants to have these types of conversations, you tend to attract an entrepreneurial set that also wants to have those conversations. And those that are still caught up in the I'm killing it framework probably don't want to spend a lot of time with me.
Do you see a business impact or the impact on their outcomes, both financially and sustainability of their solution for a longer period of time? And with that approach of being more open to accepting and having that conversation, is that something that you've seen?
It's probably too early to make that call. I mean, my own journey there and the programs that I use with my entrepreneurs are still early days. What I have noticed immediately is better leadership, more better frameworks on how you build culture that supports growth mindsets, and ultimately longer tenures as the founder and CEO of the business, because they're better able to overcome the hurdles they see as they go from seed to Series A to growth.
Great.
Alex, do you also use that filter? I mean, you talked about investing in 3 post-COVID or current COVID. What do you call the COVID companies? In COVID companies that you invested in. Why did you invest in them? And then are you also looking at how they can, their emotional stability and their ability to cope through this pandemic? Has that come into play more?
I would say that I don't know if I've quite thought about that as through that lens. I think, of course, we would assess entrepreneurs holistically and founders holistically. You know, to be very broad, of course, many startup founders are, you know, have certain character traits, right? You sort of have to be a sort of unreasonable position or be a sort of an unreasonable, stubborn person to try some of these things. You have to skew optimistic, which has, you know, and sometimes it actually has its own downsides, right? Because many times, you know, Andy Grove actually talked about this. I think it was Andy Grove, that one of the challenges actually with a lot of entrepreneurs is they're not good in a downturn or anticipating a downturn because they're intrinsically optimistic. But there's just nothing you can do about that. That's the nature of being an entrepreneur and taking risk. So I don't know if we particularly viewed it through that lens. You know, we look for all kinds of entrepreneurs. It's certainly, you know, when we're evaluating someone that we haven't met personally, you know, we might lean a little bit more in reference checking, both as much as we can, and that, you know, may have its own sort of biases, but it's sort of a thing that we do. Again, I feel like I'm not answering your question in the way you want, but there are lots of things that can make someone a good entrepreneur, and it sometimes depends on exactly the business that they're in. Certainly, some of the things that we do are require, you know, deep what a quote unquote deep tech investment. That may require having a certain team that, you know, has a background in whatever technology they're working in. The other, you know, there are cases where it's about customer acquisition or getting the unit economics right for I think Mark was talking about hardware being quite difficult. That's its own kind of challenges. And so we look for there can be different teams that are best for different kinds of companies.
Do you also invested in now? The three companies you invested in now, why did you invest in them? Do they have some sort of COVID related tailwind?
Yeah, one does. The others, nothing to do with COVID whatsoever, frankly. One company there, and the firm as a whole has actually done a few other investments. Those are just the ones that I really took the lead on, and we are in the midst of we're in the midst of closing some other investments, which I don't categorize that way because we knew the teams in advance, and so we had sort of teed up the investment prior to shelter in place. But those I highlight as ones that we didn't meet until shelter in place had already started. Yeah, so one is an approach to protease, basically going after the protease in coronaviruses. So that one is very COVID-19 related. The others have nothing to do with it. And mostly we're interested in the same things we all are, the fundamentals. So it's a strong team trying to do something with asymmetric upside, big impact. Ideally, especially in this environment that doesn't need a huge amount of capital to de-risk what they're trying to do. That is a component for decision making, because if we can't anticipate strong likelihood of you know, raising huge amounts of capital in the next 24 months, then the company needs to have a conservative plan where they're actually making progress and able to de-risk what they do. But everyone's, you know, looking for strong teams doing something exceptional, and they have some accruing advantage and some asymmetric ability or unique ability to do that impossible thing, or seemingly impossible thing.
Do you see any of your investments pivot in light of COVID-19?
Yep. There have been several portfolio companies that have refocused what they're doing in light of COVID. So I'll highlight one, and so this is getting pretty far afield from the sort of behavioral health. And so, you know, I can try to think about a specific example, but you heard from Ginger, you know, which is a portfolio company, and Russ is great. And so they've been able to, you know, sort of take, you know, what they're doing and really try to help in a different way in a time of need, but that was really their original business model. An example of a company that is pivoting, which on the surface seems quite a bit, is a company called Prellis, which is a tissue engineering company that builds 3D scaffolds organoids and tissue engineering. They were working in blood vessels, things for tumor xenografts in animal models. They're trying to build, for example, a kidney suitable for implantation in a human, tissue engineered kidney or a lobe of the lung, and that's even, they're also working for liver engineering. Anyway, there's a whole separate discussion maybe about what their kind of main vision is. Making a ton of progress, doing interesting things, and they're even selling some of their products for use in basic science research for tumor xenografts. Anyway, one of the things they had done is shown that they can build ex vivo lymph nodes. So basically external germinal centers. And their team said, look, we can do this. Let's go back and focus on that because we want to work on COVID. And so they used that to, they've identified now, I think 300. So they were able to spin up these synthetic lymph nodes, and they identified 300 unique antibodies, potentially therapeutic antibodies against spike proteins S1 and S2. And so they're advancing those as biologics, as potential therapeutic antibodies. And that has some neat properties in that they both can have a discovery platform for other infectious diseases, et cetera, but potentially even a production. Now, there are ways that, obviously people make biologics and hybridomas and registered cell lines, et cetera, traditionally, but they have a sort of unique approach even for production of things like therapeutic antibodies. And I have a long-term interest in synthetic IVIG, which is basically antibodies that are pooled from donors, blood donors, and they have some very useful properties in both people that are immune deficient, but also in autoimmunity. It's somewhat supply limited, actually, because you're limited in the number of donors, and it could be more widely used if it was more widely available and safer, because it's a human-derived product. You have to pool many people, so there are risks of viruses, et cetera. And in some markets, places like China, there is no IVIG because they don't have the collection distribution networks. That whole billion people don't have access to that powerful class of therapeutics. So I'm interested in synthetic sources of what's called IVIG. Now, let me pause because I've spoken a lot about something that's probably a pretty strong tangent, but it's an example of a company which was working on one thing. The team was really profoundly excited when they were motivated by saying, what can we do to work on coronavirus, given the tools that we have in our unique positioning expertise? And the company now looks, in some ways, in this project and what they're working on, they look in some ways a lot more like a biologics therapeutics company as opposed to the original tissue engineering optical physics technology that we originally invested in.
That's very interesting. I know that it's not directly linked to behavioral health, but it definitely links to resiliency for entrepreneurs for sure. So David, are you seeing changes in in the population that you serve and the COVID impact on that? How are you delivering care and the care models in your environment?
Yeah, our utilization of telehealth has skyrocketed. As I mentioned in the previous breakout, just in Q3 of this year, we had more therapy. I'm not even talking about medication management, but we had more therapy visits than we did in all of 2019 put together. And we also had higher number of unique users of psychotherapy over telehealth in Q1 than in all of 2019. And that's particularly fascinating because Q1 ends at the end of March. And so really the COVID California shelter in place happened around mid-March when we really saw that big spike there too. So I'm very eager to see what happens in Q2 with those numbers to learn so much more. But I think one of the most important things that really happened with the expansion of telehealth for Medi-Cal members is that the state altered the definition of telehealth to include telephone only, which allowed access for many, many more people who otherwise would not have had access through otherwise HIPAA compliant technologies, whether they would need a smartphone or a tablet or computer. Now they're able to have either a therapy appointment or a medication management appointment through just the telephone.
That's fantastic. Your quote is all over the place at this time from us because you were in a breakout session with us.
We already pulled that out and noted that, David, so thank you.
Well, I quoted myself, and I don't mean to be a broken record. It was just that I don't have Q2 information yet. Bring me back in a month. We'll see how it comes.
And as we talk in this panel, we wanted to focus on, how do we look at treatment and outcome? And then I also wanted to talk about how do we develop payment models, and especially David, in yours arena, you do deal with populations that are almost at the shoestring budget. So how are you? What are the changes you're seeing from governmental level and then from payer perspective?
Sure. Well, there are now requirements that a telehealth appointment must be paid at the same rate that an in-person appointment would be paid out. You also see, before a moment ago, you asked me about population differences, and we're also sort of diagnostic category differences where, top 5 categories of people who are utilizing telehealth before, 2 of those diagnoses were ADHD inattentive type and ADHD hyperactive type. Those are no longer among the top 5 diagnoses for people seeking telehealth. Now it's major depressive disorder, and then 4 different types, and PTSD, and then 3 different types of anxiety disorders. So you're seeing sort of a population in terms of diagnostic impression, or people who have different kinds of levels of care seeking and receiving that care. And I also think that it's with removing the barriers and communicating to large portions of the population that telehealth is available and you already have this benefit and you don't need any new equipment. And if you do, then that's fantastic if you can still do face-to-face with a therapist or a clinician over those devices. But the thing that might have impaired someone before from actually following through with an appointment, the more barriers you can remove to that access, the better. So I think that we're only going to see these numbers continue to grow as we move forward. And the payment models are fascinating because they're, at this point, they're really, like I said, they're paid out at the same amount that you would pay out for an in-person visit. So I think in terms of value-based payment, someone discussed earlier on, there are many models that we'll continue to look at moving forward as we're able to do so and have more data.
And would you see outcomes improve as a result of this shift in care delivery model? Just like Brian mentioned that, anecdotally at this point, until the data becomes available, the entrepreneurs could become better leaders and better CEOs. Yeah. Yeah,
I would definitely expect so, largely because treatment adherence is higher when folks use telehealth. The no-show rate is dramatically decreased. People are much more likely to engage in more therapeutic sessions where an average Medi-Cal number of visits is lower than when not using telehealth than when using telehealth. And so the average number of visits, because people might actually remain in treatment probably throughout the course of, like, closer to their actual treatment plan that they would engage in with their therapist. Part of it might be because people are stuck at home and they don't have anything else to do, so why not go ahead and have a therapy session? I mean that a little bit playfully, but I would hope to see that continue on in a post-COVID. And we would say post-COVID, I would say post-shelter-in-place environment, because I think COVID is going to be sort of a new reality.
Yeah.
We should, Alon, but I do want to follow up with David, because it was something in our last breakout session that you mentioned in terms of trying to develop new coping skills. I don't know if you remember saying that at our last breakout session, but so the last panel we had, we talked a lot about the increased demand, a lot about the increased access. We didn't really talk specifically about new ways of new treatment models and new I guess ways to train people, teach people how to cope. And you touched on that at our last breakout session. So would you mind elaborating on what you mean about we should be focusing on developing new coping skills?
Right. So what happened is when you have a model for like how you cope with adversity or challenges or things that are stressful. And when you don't have access to all of those things, you have to identify other ways to cope. One of the pre-questions was really about how do you prepare for a mental health pandemic, I think was the way that it was written down too. But it's really that building up of baseline resilience so that when we're not in the state of crisis and you're not in the state of being, exposed to traumatic events, building up resilience in a way that is going to have to be personal for you. But for me, I'm an extrovert, so I build up social relationships, build up value in those relationships and closeness with other people, which works for a lot of people. Some people find that antagonistic or find that stressful, right? So, so it's building up the resilience and building up that inventory of coping strategies that do work for you during times of lower stress, so that when the spike in the stress moment happens, if you're thinking about the way, the wave of it, like a heart monitor, when the spike in stress happens, if your baseline resilience is already enhanced, then that spike won't be as intense as someone whose baseline resilience is, if they have a higher vulnerability as their baseline than resilience.
So Alon, are you helping with your virtual therapies? Are you helping people become more resilient, and are you helping them raise their baseline resiliency as David refers to it?
I think it's all over, it's all the spectrum. So I think especially with COVID, what happens is a lot of people that were kind of the borderline of, do I need professional help, or is talking with a friend or a neighbor enough, got to the point that previous challenges and COVID topping on them got them to the point of realizing that they need more than that, and to address it in a more professional way and to seek treatment. So for some of them, obviously it's resilience. For some of them, it's just genuine life challenges. Every time people ask me, like, who's your customer? Who's your target audience? I say it's people with pulse, because it's really the need of therapy and the need of counseling and mental health help is not dependent on whether you're rich or poor or your political alignment. It's really about life circumstances that can happen to anyone. And it's just life, and we see that. We see people expect online counseling to be something that is more geared toward young people or more tech savvy or people living in the coast, and that's actually not the case at all. It's really all walks of life.
But Alon, you have two kinds of solutions, right? So one is direct to consumer, the other one is enterprise solution. Where are you seeing more utilization, and any specific pattern of usage that you're seeing more so that's insightful?
So the pattern of the actual users is exactly the same, whether they come from the direct to consumer channel or whether they're sponsored by enterprise, such as an EAP or an employer. The direct-to-consumer is much simpler in the sense that the user and the person that you need to convince are the same person. On the enterprise, you have the user and you have some gatekeepers along the way that needs to be convinced with value. Personally, I think that going direct-to-consumer is very helpful also to make an enterprise case, because when you come to enterprise, you're not saying I have a theory that this would work. We have over 1 million people that use this and paid us, and over 70 million sessions. So when we go now to an enterprise, we come with a lot of evidence that this is working, and this is something that people want. This is
I think you cut off. So David, would you be more likely to partner with a company that is B2C and shows that they have demand versus a company that goes directly B2B2C and goes to you with evidence-based studies, but not the critical mass of users?
I think it would depend on if you wanted to maybe pilot in one clinic or something like that. If we don't have one or the other, and in some cases we might pilot something or purchase like in a like in a private clinic that we run our own. But in terms of being able to offer it to like a wider spectrum, you know, if you're talking about like a Medi-Cal population, we have something like 400,000 Medi-Cal members, and to be able to offer something to one person means to offer it to everyone. So it needs to be a platform that is tried and true, but also one that we know is accessible for our members, something that they're able to absorb and digest. So we'd have to look into that quite a bit more. But when you're saying directly from B2B, could you explain a little bit more what you mean by that, like about going direct to consumer versus B2B?
A company selling to you to sell to, just like Ginger.io is B2B, so they would go to the enterprise, the self-insured employer, and then the self-insured employer goes out to the patient.
So unlike
Right.
BetterHelp that goes directly to the end user, which is the patient, and Ginger.io goes to a company like, for example, HP, and then goes to, and then HP markets it, and then potentially we don't have affiliation with Ginger. I just want to be clear, but having said that, that's kind of the two-step process. So it is the enterprise that's marketing the solution, for example.
Yeah, I want to switch to, did you have a response, David, to that?
Yeah, I was going to say we do both. Yeah, I mean, because we also utilize, we utilize Teladoc for our membership as well. So they can go in through the platform, which we put out, and we tell all our members this is something that, you know, that it is paid for and that you have access to, and that you can access mental health services through Teladoc. We don't tell each of our providers to which platforms to use, though. So we could have like our contracted mental health providers that might have their own specific devices and platforms that they use that their members can access them through, but the reimbursement is the same.
Okay. And BetterHelp is part of Teladoc, Teladoc, BetterHelp's parent company. I want to switch to outcomes and for everyone to talk about this, because we didn't really touch on this before in the last panel, and it seems the way we measure success is really through the PHQ-9 and the GAD tests, and you take it at one point and then you take it again and you measure that. And are we seeing any other other ways to measure outcomes? Are we seeing objective?
If I can jump in on that one too. And PHQ-9 is good for a clinician to measure change during the course of treatment, but it's not really how I would measure outcomes, because as a payer, I get a report that a PHQ-9 was conducted, but I don't see the score on it. So I might see a depression screen was done once per year and I pay for it once per year. But what I do see is the overall cost of healthcare of those members who maybe were screened for depression, had a diagnosis of depression, and then accessed treatment for depression, versus people who were not screened at all, or people who were screened positive for depression but did not access treatment, and see the overall cost of their healthcare, who's going to the emergency room more, who's accessing, who is or is not getting treatment for their diabetes. I can also see if someone has a prescription for an antidepressant and they are not, or they are refilling their diabetes test kits, or that they're getting these sorts of things. So you can really do all sorts of ultimate cost of healthcare based on who is accessing which kinds of behavioral health treatment, and see those correlations as they move out. So it's not just PHQ-9 to PHQ-9, which is, like I said, it's good for having those conversations. It's good for more. But it's through the course of treatment, those can fluctuate. It's not like you have an illness and you get treatment and you're cured and that's the end of it and you no longer have that illness. I mean, mental health conditions are often revisited throughout the developmental lifespan. So it may be resolved. I mentioned earlier, like you might have something that was resolved during adolescence, but then when you're in your 20s, you have to revisit the same issues, and like you go back into treatment. So PHQ-9 alone, it's just not linear.
So it seems like,
Alon, do you use PHQ-9, and then also how do you measure
clinical outcome?
Oh, I had a question for Alon.
Mm-hmm.
Okay, so Alon, do you use PHQ-9? How do you use it? When do you use it? And then also, how do you measure your therapists and how well they're doing?
So we use both subjective and objective measures. Subjective would be applying feedback and rating and NPS the same way that any consumer application would do. And then we do things that are more specific to therapy, like PHQ-9. We do this both to track outcomes and to assess who are the better counselors, because we match clients with counselors 2,000 times a day. Also, studies that have made a recent one by UC Berkeley, UCSF, and St. Francis General Hospital about outcomes used PHQ-9 just to measure reduction of depression symptoms, comparing people who've gone through BetterHelp 3 months versus traditional brick and mortar therapy, found that the reduction is the same, also based on PHQ-9. So we use it to check ourselves and check our therapists, but because it's not paid by a payer, most of the time it's the consumer. The consumer is not really interested so much in the metrics that people here are interested. They're not interested in progress reports so much. They're not interested in metrics in showing outcome. They're interested in getting better, and they're a really good judge of whether they're getting better or not.
So it seems like both from David's perspective, you're looking at utilization data as outcome, and also maybe the cost data as an outcome, and access and other things. And from Alon perspective, it's more experience and of course the clinical outcome, which is the PHQ-9 progression or GAD-7 progression, right? So it's two different outcomes that you're looking at.
I would like to point out, I don't disagree with Alon whatsoever. And as a clinician, that's where I would go. I was responding just as a payer, though, for the side that I see.
Okay.
We do have a somebody who would like to ask a question. So I'm just going to open it up, because I know every time we do that, more people like to ask questions. So this one is Ali Amrani. Go ahead. I have unmuted you.
Okay. Yeah. Can you hear me?
Yes.
Okay. Hey, thanks, Bambi. Thanks, Archana. These past couple of sessions has been great. Question is that, so a quick background, we are a digital mental health platform. We are empowering providers to offer asynchronous therapy with our clinical validated materials and CBT materials, and also AI-assisted tools. So when we are coming, so that's the kind of question every time we get. So we go to some people like MD Live, BetterHelp, and say, hey, with addition of our tool, you can see 4 times more patients. And then they come to this question, okay, why I should do that? Because they say that regardless, if you are basically increasing my productivity, we are already filled my hours and I'm not getting paid more by the payers. Then we go to the payers, we say that, guys, we are assisting you, so same providers give you more productivity as well. They say that, oh, it's great, we know we want to reduce the cost, but it is payers' choice to what to do. So what is, because, and I think the main issue here is that the payers is just paying by hours, and the provider doesn't see any incentive to increase their outreach, their productivity, their monitoring tools, their report. So what is your answer to this question? Because really this kind of, for us, it's kind of, we are trying to solve this equation. We are saying that there are many people who are needing help, so don't worry. And so this is kind of a weird question all the time, but also it's partial is, you know, what payers usually are afraid is that if they increase the productivity and their access, there are more people who are going to use it and they are paying more. And we are always trying to say that, don't worry, because if you pay upfront for mental health issues, you are going to de-risk that health issue of that patient in a long term. So yes, you probably see a spike in usage of mental health, but in long term, it's going to pay out. So I want to hear the panelists talk about it, because this equation is always kind of challenging when you are talking about. So payers say that go ask the providers say that go ask the payers to pay it, because they are the one who are monitoring our performance.
Who wants to take a stab, Alon or David? Because you know the question is for both of you. David, do you want to go first?
It's more of a payer question.
Sure. Yeah, I can. because I'm with Medicaid and Medicare, it's going to be a little bit, unfortunately, a little simpler, is that these things are dictated by the state and by the Fed. So there are reimbursement rates that are by minutes of therapy, they're in time increments. With asynchronous utilization, there just aren't payment models that government line of business is capable of translating those to. Not that it would be impossible for a commercial line of business, though, but it would have to be a different kind of negotiated contract model, so that you would be able to identify what are the pay points. You know, like there are some, I mean, there are pay points, there are security issues, there are like some fraud issues that you'd have to really be mindful of as well. If you're doing asynchronous, you want to make sure that people aren't getting cookie cutter responses, that sort of thing, and getting paid as if it's therapy. So, but that being said, I think if you had a payment model to propose to a payer, to a payer contracting department, it might be something to pilot in a smaller market.
Do you think there is value-based play here with the asynchronous solutions?
I don't think as a standalone option. I think that, like, if you're going to use some kind of asynchronous model, it would have to be on top of a time-based reimbursement model.
Okay.
I just want to say how this question is important. I don't have an answer in, because we're not covered by insurance. It's not something that we lose sleep on. But our pricing model is basically the user is paying a flat subscription fee. And for that fee, they get to work with a therapist in full modalities. There's synchronous messaging, no need to schedule, and then the live chat, live session that they can schedule from the calendar of a phone, video, or chat. I'm mentioning this because it doesn't cost anything more to the member to use these live sessions. And still, around half of the members prefer to use just messaging, either just completely messaging or predominantly messaging. Although they can do the video, they can do the phone, they can do the live sessions at no extra cost. That's their choice, which means that this modality is really very effective because of its convenience and its accessibility, also a little bit more feel of control and safety. And I wish payers would find a way to code this and to fix the process. The way we pay counselors, which can be kind of an inspiration to this model, is based on number of messages and length of messages. The same way that you pay differently for a 45-minute session or a 90-minute session, then you pay differently for a message that is 200 words or 1,000 words. And there are some safeguards, you know, that the conversation actually makes sense. So it's not just a one-sided conversation. But there are definitely ways to code it and to reimburse for it. But it requires a thinking that's it's not yet in existence, not just in mental health, but in any kind. I don't think also in medical you have doctors now interacting with patients over sort of email, compliant email, and that's a struggle too to get this reimbursed.
I think the biggest incentive here is that the doctors were able to get paid for the telehealth services. We've done a number of these breakout sessions and talked to a number of physicians who've said that, or a number of clinics who said that initially they had a number of physicians who wanted or who didn't want to do remote care, telehealth care, because, well, they weren't getting paid. And now all of a sudden, that's all they want to do is telehealth, because they're finally getting paid. But to David's point, that is sort of for him, it's easy because that is they're paying for it. But for the self-insured employers like you, Archana, it's not something that's still unclear whether that will still be paid for in 6 months. So I'd be curious to hear from the two VCs. You know, you have Alon, who doesn't really, right now, he's fine. People want his service and they're paying him directly. His therapists are happy. But there are a number of others who have a future that's clearly uncertain because they're not quite sure what the payments are going to be, the reimbursement's going to be. So as you think about that in the companies that you invest in, how are you looking at that, and how is that calculated into your decision-making process in terms of whether you work with a company or not, or how you're counseling them on to move forward. This is for the 2 VCs.
Sure, I'm happy to go first if that's helpful. So from our point of view, I think we found that relying on the payer networks to provide reimbursement, or even counting on self-insured employers, very difficult channels to navigate. And for us, it's been really hard to find, healthcare tech related investments that can get to mass adoption without having some way to get insurance coverage. So for us, what we have found is finding really large volume, but I would call niche communities. So think of something like hypothyroidism. Very difficult to find high quality care and because of a lack of doctors that can properly diagnose and treat that. And very targeted communities online that are actually easy to get to from a cost of acquisition tend to be the types of opportunities that resonate with us. So we do stuff in pet care, we've done stuff in hypothyroidism, we've done stuff in cancer care through self-insured employers, very difficult to get them to sign on. Even though the idea of providing a better care experience for someone navigating their cancer journey makes all the sense in the world, it's very hard to free up those budgets. And so it's a difficult one, and it makes the space very difficult to invest in.
Do you, as a result of COVID-19, have you made certain portions of their offering a little bit more upfront? For example, a telecare component as an essential element of their offering for your investment?
Sure. I think in all of the cases within our portfolio, there is an element of teleconsult that then leads to diagnosis, prescription, ongoing compliance with care through digital texting technologies, et cetera. And then I think the key piece there, to go back to that payer-provider dynamic, is when you can actually prove that you've delivered better care at a lower cost with higher, I wouldn't necessarily say, well, I would say efficacy, right? Then you start to see the payers pay attention, or the providers realize, oh wait, if I added a digital component to our cancer treatment, we would have better compliance with our treatment recommendations, and thus a better experience for the consumer, and thus it differentiates why you would come to us for cancer care versus another hospital provider. So we watch that entire thread, but they're very long life cycles to get to the point where you have enough data to validate any of it.
Yeah, I mean, healthcare is long cycle anyway, and unlike anything else. Alex, do you see that? Yeah.
Well, we have a bunch of different companies taking a bunch of different approaches. You heard from Ginger. We have other companies like Sword, which is in remote physical therapy, Hello Heart in blood pressure, that are working with employers. We, in general, have not focused our investments around products or technology that are very reliant on a particular reimbursement code, and things that we have that have some of that flavor, particularly in diagnostics, which have been very vulnerable to slight changes in reimbursement rate or how things are bundled or unbundled. It can be not a great position to be in if you're overly reliant on a particular margin. And we've mostly focused our investments on technology and approaches that do work in a value-based model. I think I obviously can't predict the future. I wish I could. I'd be much better at my job. But there are clearly interesting potential changes afoot, right? And many of the big insurers in the sort of fee-for-service model, right, are making tremendous profits right now because their medical loss ratio looks great because a lot of non-emergency procedures that are quite expensive have been deferred. Now, if all those in-queued procedures will suddenly, happen all at a very fast clip and it will be very expensive for them, kind of remains to be seen. That's, the concern, I think, from their position. Many of the provider organizations, of course, who were very happy in a fee-for-service world are sort of miserable right now because if they were capitated, they would be buffered from the reduction in their volume and their ability to bill. I think there has been a lot of resistance, I think, in providers in their negotiation for various forms of capitation, in that they feel like they're in an asymmetric position vis-a-vis, a group that specializes basically in risk modeling and understanding how to price, right? But that may change if there's a feeling that you can buffer yourself from potential challenges like this in the future, and there may be changes. Now, I'm all speaking very broadly because this, is reliant on, societal pressures where, a world where maybe increasing unemployment shifts demand, where there are political components to this, right? And we are entering into an election year, and so all those things can affect the landscape. I don't know what will happen. But I think in general, because we've been interested in taking a broad vision of potentially very impactful technology, we've skewed a little bit more towards a outcome-based model or technology that works in that scenario. But we do stuff that has a direct consumer component, et cetera, and there's certain advantage there, including product development, frankly, because if you can fight it out in the direct-to-consumer healthcare world where it's very challenging to go after those dollars and you have to win on product quality in some ways as opposed to your enterprise negotiation skills, that can have certain advantages, although it can be quite challenging to make significant revenue that way. I don't know if that, again, that's helpful or answers the core question. It's very context dependent and depends exactly on what particular companies are doing, but yeah.
Well, I guess it's also, and I think we're going to probably have to wrap this up, but I think it's just also because consumers are far more in control of their expenses, not so much in healthcare, but across other parts of their lives. And I think particularly with millennials, I think they're going to become used to the transparency of the pricing, and they are going to like on demand. And there's a number of retail outfits out there now, retail health clinics out there right now. So
yeah, there's a common narrative that in particular, as millennials approach some of the ways in which they encounter care, often around, for example, maternity, which is sometimes people's first, if they haven't had previous significant illness and they don't remember their own childhood, that wouldn't necessarily their early childhood and a lot of pediatric visits, that's their first significant interaction with healthcare delivery, that there will be a titanic shift in demand for kind of quality of service provided and how people think about that. I don't know if I've seen that quite play out, but there certainly, I do believe that and I think Brian talked about this, the consumer experience with telemedicine and the ease of use will make it very, very hard to roll back on willingness to pay. The same thing is true as people get more and more practical experience with asynchronous solutions. It's going to be very hard to roll that back and deny service when they're like, just worked for me a month ago. And I think there will be a shift. I can't predict exactly what will come out, and there'll be a lot of experiments. I think if you don't study it, I wish I had more time in my life to study what's going on in India. It's a very interesting situation because you have a very disparate set of care delivery. You have all kinds of different clinical labs that are big, small. You have the Apollo model, you have Debbie Shetty's model. It's very interesting because so much is out of pocket pay. You have more of a sort of test bed of different models that are being tried and piloted. There are all kinds of mobile solutions. People are trying different mobile-based EHRs that are being deployed in some states and not others, and just a huge ecosystem that lots of natural experiments are being tried, and it would be interesting even just things like not, in limited access to providers at various levels of accreditation, et cetera. So they have to kind of upskill everyone, people work at the top of their license. I think there are a lot of interesting opportunities there, and that maybe the US health system can learn from there. Is quite different, for example, from China, which is much more like top down and not, let 1,000 flowers bloom. And so the US can learn from both, because in China, they're able to, frankly, steamroll in certain things, which we wouldn't want to do here, but we can learn.
Well, I think we just steamrolled one thing right now, which is shelter in place. So right now I'm picturing everybody is in second grade, because this is what I look at quite a lot, is a Zoom homeschooling for, elementary school. So I think for sure, if not millennials, the Generation Z, or maybe I'll call them Generation Zoom, for sure that they're going to be demanding a different way of, hey, I just made that up, to Generation Zoom.
Well, I think
different ways to access healthcare.
I do want to comment on what Alex was mentioning, is because, HP, for example, is global, and what we're learning is like heavy use of technology in certain Asian countries, including China, and an integrated, interconnectivity through having that technology is extremely helpful, especially in the times of COVID. And then we look at India, and especially when I was rolling out some programs there, we noticed that how access to primary care is very fragmented, but there's catastrophic coverage in the country. So there's a private-public model that is quite unique in India. And so there's several things we can learn, how each of the countries responded to COVID, or how they innovated in those countries, and what did really truly worked. And that could be quite interesting for the US too.
Archana, I think we have Ali wants to ask another question, and then we would probably have to wrap it up.
Yes, and we have the last two questions that we have planned. Ali, do you want to jump in and talk?
Yes. Okay, great. So through these times, we have been talking about accessibility and kind of making it mental health more affordable and accessible. So some of the challenges that we see in the market, beside that reimbursement, which is still for digital mental health, is not there, is that, do you think the insurance groups are essentially going to reimburse, because there's a codes for basically data that has been collected from medical devices. But do you think if, for example, mental health is more complicated, so a simple data from your Apple Watch about your activity and others also can help to generate some related reports?
Okay. Will the insurance companies reimburse for Fitbit and other types of wearables? As David, you could probably answer that.
As a kind of data collection tool.
Do you mean to actually like pay Apple or pay Fitbit for the data?
So let's say that, let's say right now mine is trying to do everything with your mobile phone. So there are other ways we say that, okay, there's right now other devices that people are using, which is collecting data that which can be very useful for mental health team to predict the status of the mental health patient. They are not technically medical data, they're predictive data. So when we are collecting that data, so there's a cost for the mental health provider, for digital health platform, and also that wearable device. So traditionally, if you have a heart rate monitor, the insurance will pay you because they know that this is something that they know, this is very medical. But these data are mostly metadata and not necessarily medical data. They are going to be processed. So do you think the reinsurance are kind of willing to kind of subsidize paying for generating report from those data as well? They kind of say that, yes, that data is also can be seen as medical data. So that's why we are going to pay for report generated by those data, or data, see them as a data collection tool and pay for example, that Apple Watch as well.
Thank you.
Not medical, no. We wouldn't be buying the devices, and I think if we had like an agreement, it would depend on the contract with the company that was collecting the data, perhaps. But I think we're a ways off from collecting predictive, or certainly for funding predictive data like that, unless there was like a specific sort of contracted or grant relationship with the provider in the first place.
And I think from giving out devices like those, it is utilized in high cost claimant population. For example, people with congestive heart failure, we want to keep them outside the hospital. Those are scenarios in which the devices like these are utilized. Yeah.
And I think health payers' responsibility is to diagnose and to treat. So this could potentially fall under the category of a diagnostic, but for ongoing data collection without the purpose of diagnosing or treating, I think you'd have a hard time finding a health insurance payer that would engage in that relationship unless they were really interested in that type of innovation relationship.
Yeah.
The way this has been deployed in things like diabetes, right, or around bundled programs where you will get a glucometer or a connected scale combined with an ADA or CDC approved diabetes education program. And so it's a whole bundle, because Brian said it's not diagnosis for the sake of diagnosis. Diagnosis to some extent is customer acquisition for someone else's therapeutics effort, right? And to figure out how to best deploy that. I'd note that Ginger.io actually has a significant amount of technology and IP in this space coming out of MIT Media Lab on using mobile devices to evaluate people's mental behavioral state. It just is not really part of their current business model, but it's a big part of the origins of the company and something that they still have. We have another company called Ellipsis, which is a voice-based biomarker for mental health. They can get 90% concordance with PHQ-9, which is within repeatability of the test, and basically at the level of the test just based on voice. There's some other groups that demonstrated similar things, but I think really it's you need to you're pitching this as an outcome diagnostic. It's really the valuable thing is to bundle it with a therapeutic. We've got the study that Mimi cited before, right? 68% of people in the U.S. that make under 25K a year are expressing uncontrolled worry right now in the world of COVID and employment insecurity. So this is a huge issue in terms of access to care. We're pursuing some efforts in technology that we think is very deployable at very low cost point. So we have an effort in Europe called Flow Neuroscience. It's CE mark approved. It's a headset for transcranial electric stimulation, which is sort of the electrical version of transcranial magnetic stimulation. And this would enable, it's a very low cost device and comparable to the cost of even generic pharmacotherapy amortized over a year and a half. So I think there are approaches. Some of the app-based approaches obviously are essentially free to scale. I do also see that there's an assumption in a lot of places that people will have smartphones, and of course they're widely deployed. But my understanding, and David may know, that much of the telemedicine care in psychiatry right now, as delivered, is being done through regular phone channels, because many of the clients, for whatever reason, don't have access to data plans or technology to do through any other modality. And so that's important to keep in mind, is that the many people that need these tools that are cheap and scalable and efficient actually may have relatively limited channel access to technology.
Yeah. I mean, we were talking to some medical groups in the middle of America, and a lot of their clients do not have a smartphone. So
I would also argue that diagnosis is not, I don't know if it's a big challenge, but it's definitely not the challenge that you want to tackle with smart technology. We mentioned PHQ-9, and other things. It's actually pretty easy to diagnose someone whether they have depression or not. And sometimes I feel like we're trying to force technology where it's not really needed. The people who would put, like the quantified self people that would put Apple Watch in and measure their heart rate to see if they're in depression, they're very aware to their mental health. The blind spots are not there. The blind spots are those or not even close to that. And the big challenge is not diagnosis, it's bringing those people to care.
We have a couple of you have hard stops at 4 p.m. So I want to be cognizant of that. So Archana, we should wrap.
Yes, we should.
Wonderful questions.
Yes, so we have a couple of questions from each of our panelists, and we would like to know from you, what is positive that has come out of this COVID crisis in your arena? Like what kind of innovation or other things that you're seeing that's positive, and what is it that you want to see go forward in the new normal of COVID world? And I'll begin with Alex, because you are on the right top screen next to me. So,
as mentioned, I'm very excited that telemedicine will get a significant tailwind. I think the utilization of remote care has a tremendous number of advantages in access to care, potential improvements in quality of care, instrumenting that channel. What I hope will happen is that it will provide, we will have reimbursement and pay incentive models and structures in place to actually deploy some of this technology, such as some of these connected devices, which do have value and at scale can become quite cheap to produce, but haven't necessarily had the right incentives and structures in place to deploy them. So I do think, you know, it's not technology for the sake of technology. The advantages are that it can make the cost of health improvement, wellness, much cheaper to effectuate. And I hope the shift in more remote care just will give significant drive to the ability to deploy and support those technologies and approaches.
thank you, Alex. And that I just want to do a huge plug-in for our next session that we are doing on virtual care and the future of it. So I do want to highlight that the people who are watching and listening, please do tune in for that, because that is kind of the future that looks like. David, you're next. What is going well, and what is your wish list?
I would say I couldn't agree with Alex more. I think that the access to telehealth has really just leapt because of COVID. I got to tell you, before some of the new permissions that were provided by the state, I was not a believer, particularly about telehealth for the use of behavioral health treatment for children with autism or other children who are receiving applied behavior analysis. I was definitely in the camp of like, no, you need the person in the room. I have seen outcomes that actually have completely dismayed my belief system that was not necessarily based on data, because there wasn't data previously, because no one was allowing telehealth for those. So now that we have allowed telehealth for direct services for applied behavior analysis, we actually have the data, and I'm making the switch over, and I think that other Medi-Cal payers will be as well. So we'll see. We'll of course continue to abide by all state and federal regulations in terms of what we permit and what we offer and pay for. I would really like to see a continuation of telehealth moving forward, and particularly for telephonic only based. We'll see what the state comes down with though.
Great, thank you. Brian, what are you seeing good that happened, and what's your wish list?
Yeah, I think from my point of view, the positives of this has been the tailwinds or accelerant behind more broadly what I call self-care, both professionally and personally, and taking the time, whether it be mindfulness or stretching and yoga, all the way to what I call more alternative treatment modalities, more holistic care, and the exposure that this time at home and time to yourself has been able to open up to people that maybe haven't seen it before and haven't experienced before. And so that's been really positive. We have a company called Kensho Health that is, a provider network of alternative treatment modalities, thousands of practitioners, and almost in a community orientation, they started offering up Instagram live sessions to give you your first experience with breath work or Reiki or whatever it might be. So I think that's been really positive for society as a whole. What I hope to see is more of those alternative modalities become more mainstream, which means pushing deeply into the way healthcare is delivered broadly. And my other hope is that this COVID dynamic opens up the eyes to the imbalance of care that has been given to the various various demographics of the United States. It's been pretty eye-opening in the haves and the have-nots, and that's been disturbing to see, and I'm hopeful that this can drive more awareness around that topic.
Thank you. How about you, Alon?
The good thing I think is actually on the provider side. Users and consumers were already going there in masses and droves over the last few years, and we've seen it very consistently. But what I think changed with COVID is that providers were forced to face this reality. And the great example I have is in 2012, when we just started thinking about the idea of BetterHelp, the first therapist I went to talk to, like I mentioned, I'm not coming from health background, just a local therapist here in Palo Alto. And she hated the idea, like completely. You have to be in the same space. There's so many cues that are not even visual, and just the presence of two people in the same room is so important. Obviously, we decided to ignore and to move forward anyway. But fast forward to 2 or 3 weeks ago, when I just, in complete serendipity, talked with her and asked her, how's it going now with shelter in place? And she said, well, I moved everybody to Zoom. And I said, how's that going? She said, that's actually pretty good. So that's a shift that the clinicians and the providers just have to accept and realize now. So that's, I think, the biggest positive. It's also accelerated, like David and Alex and Brian mentioned, it accelerated the consumer, but it was something that was already going on anyway. My wish list is very specific, and I think I talked about this in one of the previous salons, is state lines. State lines in telehealth makes absolutely no sense. It is very detrimental to the care of people. You have a smaller pool of providers in some places. You don't have enough providers. It serves no purpose at all. And I think it is time to rethink about why don't we let a consumer in California work with the best therapists that they can work with just because they're across the border in Nevada.
Yeah, I cannot agree more. Temporarily, a lot of emergency orders have opened up the borders. And as a practicing clinician, I have patients all over the country, and I am temporarily licensed in different parts of the country, and it is tremendous benefit to the patient and myself. Bambi, back to you. It's a wrap, right?
It's a wrap. And
Yes.
just to follow up with what everybody was saying, that yes, we have seen an acceleration of these new technologies that are clearly in demand, and that's a good thing. But I think at the same time, we've also become still. Sheltering in place has definitely allowed us to become still, and there's been a reset. And as I said before, this pandemic has taken away what we want, but given us time to pursue what we need. And in that moment, I think that it's changed our priorities around, and we've been able to reflect, and we've been able to renew relationships, hopefully, even if we're angry at one another, we still can come back and forgive and apologize to one another, which is a good cycle to go through. So I'm really grateful for that reset and that time for us to re-examine our priorities. I also am grateful that we've talked a lot about stigma and the decline in stigma and this acceptance of our human condition, which I think for the last 100 years, people have not thought about that. It's always been that we are extremely resilient, but as David mentioned, there are certain baselines of resiliency. And I think that once we understand that we're inherently broken, I think that makes it easier for us to talk to one another and to become more resilient and learn how to become more resilient through hopefully our social support structures or a lot of what everybody's creating on this call. And then finally, I think from the innovation side, I really hope that we could, as David mentioned, sort of find these new coping skills and ways to become more resilient. But then it's also, as Nina talked about, really focusing on the disease. I hope that there are more treatments that focus on the disease. And because we really need help in that area as well, not just across the spectrum, but really those who have significant chronic conditions. That's my wrap. What about you? Did you want to end it or? Okay, well then I guess I'll wrap it up.
Yes, it's a wrap. I think I've been
Stay hydrated.
chatting quite a bit. Thank you so much. Thank you, panelists, for joining us, and appreciate your time.
We'll see everyone June 10th for our virtual care event. And
yes,
thanks everyone. Stay safe and sane.
Excellent. Take care.
Thanks
Bye.
all.